Bismillah ar-Rahman ar-Rahim. Today, our first lecture in cardiology chapter, we will talk about heart failure. Heart failure is a big topic, but in our lecture, we will focus on important concepts related to heart failure. We will talk about the pathophysiology of heart failure because this is very important in order to understand the management strategies for heart failure. And we will focus also on the pharmacotherapy of heart failure. So first of all, what is meant by heart failure? The definition of heart failure, the complete definition, it's a clinical syndrome. It's a complex clinical syndrome that develops when the heart is unable to pump adequate output or able to do so with elevated filling pressures. This is a very important term that we need to understand, elevated filling pressure. And when we talk about the pathophysiology of heart failure, we will come to understand what is meant by elevated filling pressure. So basically, heart failure is a state in which the heart is unable to provide adequate cardiac output, or the heart is able to provide adequate cardiac output, but only with elevated ventricular filling pressure. And the only way by which the failing heart can maintain adequate cardiac output is by increasing the ventricular filling pressure. So we would like to understand what is meant by this increased filling pressure, because this increased filling pressure is the reason why patients with heart failure will eventually develop congestive manifestations. For example, with left heart failure, patients will develop pulmonary venous congestion or pulmonary edema, and the patient can present clinically with dyspnea. And patients with element of right heart failure, they present with systemic venous congestion, and this can lead, for example, to tender hepatomegaly, and it can cause peripheral edema. All these different congestive manifestations that are characterized and associated with heart failure are related to the elevated ventricular filling pressure. And this is because the failing heart will depend on this increased filling pressure to maintain adequate cardiac output as a compensatory mechanism. So let's talk about the pathophysiology of heart failure. And this can be considered as the most important section when we talk about heart failure. This is the key to understand the whole topic. As you know, heart failure has plenty of underlying causes. It has a lot of underlying causes. It can be acute heart failure, or it can be chronic heart failure. But in this figure and this picture, we will discuss the pathophysiology of heart failure in general, regardless of the underlying cause. So heart failure will start with a specific underlying cause. For example, let's take one example, myocardial infarction, which is an extremely common cause of heart failure. And myocardial infarction can be followed by heart failure. So let's suppose that we have a patient who had myocardial infarction. This myocardial infarction can result in heart failure. And with heart failure, initially, there is reduced cardiac output. So this is the initial problem. As we all know, heart failure basically means low cardiac output. So the initial problem here, the initial hemodynamic disturbance with heart failure is reduced cardiac output. This reduction in the cardiac output will result in reduction in the blood pressure, as we all know, because the blood pressure equals the cardiac output divided by the total peripheral resistance. This is a common physiological equation. So the blood pressure is directly proportional to the cardiac output. كل ما نقص the cardiac output, the blood pressure will drop. So this reduced cardiac output will result in reduction in the blood pressure. Reduction in the blood pressure is a deviation from the normal homeostasis of the body. The human body will not accept this reduction in the blood pressure. And so there are different compensatory mechanisms which will start to develop, and it will become activated. And these compensatory mechanisms will attempt to normalize the blood pressure by normalizing the cardiac output as well. But the problem is these compensatory mechanisms that we will discuss during this lecture, these compensatory mechanisms, although they are beneficial initially, they maintain cardiac output and they maintain blood pressure. But eventually, on the long term, because these compensatory mechanisms will remain activated for long duration, perhaps for years. Here we are talking about chronic heart failure. In a discussion of our pathophysiology, we are focusing on chronic heart failure. The compensatory mechanisms will remain activated for long duration, perhaps for years, because the underlying condition tends to be irreversible. There is a myocardial infarction, for example, or there is dilated cardiomyopathy, whatever the cause of heart failure leading to chronic heart failure. So as long as there is a permanent damage to the heart and there is a permanent problem, this will result in chronic activation of these compensatory mechanisms in an attempt to correct the cardiac output and to correct the blood pressure. Initially, these compensatory mechanisms are beneficial. It will help to maintain adequate cardiac output. It will help to control the blood pressure, and so it will help to maintain metabolic demands of the tissues. But on the long term, after several years, these compensatory mechanisms will exert negative impact on the heart and negative impact on the circulatory system overall. And it will result in some secondary changes that will develop on the heart. And this will include structural and functional changes. The heart will undergo, the myocardium will undergo structural and functional changes after many years following the activation of these compensatory mechanisms. And the collection of the structural and functional changes that will develop in the heart in patients with chronic heart failure, this is called cardiac remodeling or ventricular remodeling. And this is a very important concept that we need to focus on, because our modern pharmacological treatment of heart failure is aiming at slowing down the process of cardiac remodeling. We want to slow down the process of cardiac remodeling, because this cardiac remodeling, these changes in the myocardium, is what will make heart failure progressive disease. This is what results in the progressive and chronic nature of heart failure. So if we were able to slow down and to reduce these changes of cardiac remodeling, we can actually improve and reduce the mortality in patients with heart failure. And so during this lecture, we will mention and we will talk about several drugs that have been found according to several clinical trials and studies to be associated with mortality benefits, to reduce the mortality. And drugs that reduce the mortality in heart failure, they reduce the mortality by acting on the cardiac remodeling, by slowing the progression of cardiac remodeling, by reducing cardiac remodeling. So let's see how this cardiac remodeling will develop. As I said, cardiac remodeling is the result of long-standing activation of different compensatory mechanisms. And these compensatory mechanisms are activated secondary to the drop in the cardiac output and drop in blood pressure. So what are these compensatory mechanisms? These are neurohumoral mechanisms. They are called neurohumoral mechanisms. Neurohumoral basically means, there is neurological factors and there are humoral factors. Humoral factors basically means hormones. So we have contribution from the sympathetic nervous system specifically, and we have contribution from different sets of hormones. And we would like to know how these two systems eventually will initially, it will be beneficial in heart failure, and eventually on the long term, it will have negative impact on the heart. So the neurological part of the neurohumoral mechanisms is related to the sympathetic nervous system activation. So how can activation of the sympathetic nervous system will initially maintain adequate cardiac output and initially correct the blood pressure? The sympathetic nervous system the sympathetic nervous system is one of the compensatory mechanisms which will be activated, and it will attempt to restore the cardiac output. It will maintain adequate cardiac output, and it will correct the blood pressure. And it can do so by several mechanisms. First of all, a sympathetic nervous system has receptors on the myocardial cells, and these are called beta-1 adrenergic receptors. By activating these receptors, the sympathetic nervous system will increase the heart rate and will increase the contractility of the myocardium. And eventually, this will result in an increase in the cardiac output, because as we know, another equation, the cardiac output equals the stroke volume divided by the heart rate. So when we increase the heart rate, the cardiac output will automatically increase. And when we increase the stroke volume, the cardiac output also will increase. The stroke volume will be increased mainly when there is increase in the myocardial contractility. So the sympathetic nervous system, by acting on the beta-1 receptors of the heart, it will increase the heart rate, and so it will increase the cardiac output. It will increase also the myocardial contractility, and this in turn will increase the stroke volume, and increase in the stroke volume will result in increase in the cardiac output. Stroke volume is defined as the volume of blood ejected per each beat. Yani per each heartbeat, the volume of blood which is ejected, this is called the stroke volume. And the cardiac output is directly proportional بتناسب تقديا مع الstroke volume ومع heart rate. So this is one mechanism by which the sympathetic nervous system will maintain adequate cardiac output by increasing the heart rate and by increasing the contraction of the myocardium. And by increasing the cardiac output, eventually this will increase the blood pressure. So this is one of the important compensatory mechanisms. Then there are other also mechanisms by which the sympathetic nervous system will contribute by acting on the peripheral, not acting on the heart, by acting on the blood vessels. On the blood vessels, we have alpha adrenergic receptors. On the heart, we have beta 1 adrenergic receptors, while on the blood vessels, the main receptors are alpha adrenergic receptors. And the sympathetic nervous system, by activating these alpha adrenergic receptors, it will act on both the venous side and on the arterial side. On the venous side, when it activates the alpha adrenergic receptors, it will cause venoconstriction. It will constrict the veins. And this venoconstriction is beneficial in increasing the cardiac output, because when we induce venoconstriction, this will increase the venous pumping of blood, and this will lead to more venous return to the heart. When there is constriction of the veins, the blood will be pumped more towards the heart. And so the venous return will increase in response to venoconstriction. And this increase in the venous return will result in increase of the preload. So what is meant by the preload? Preload is an important term we need to know during our lecture. Preload in physiology basically means the total amount and the total volume of blood that is present within the ventricular chambers at the end of the diastolic phase. As we know, during the diastolic phase, the mitral and tricuspid valve will open, and this will allow blood to flow from the atria to the ventricles. And so the ventricles will become filled with blood during the diastolic phase. And this is called the ventricular filling phase also. So the preload is the volume of blood which will be present at the end of the diastolic phase within the ventricular chambers. This is the term which is called preload, which is also called end-diastolic volume. So we can use preload to indicate end-diastolic volume. They basically mean the same thing. And whenever there is increase in the preload, this will result in increase in the cardiac output. Because when the volume of blood present at the end of the diastolic phase is more, this will result in more cardiac output. And here we can apply an important law in physics called Frank-Starling law. Frank-Starling law states that بيقول إنه when you increase the preload to the heart, this will result in more stretching of the myocardial cells. And when the myocardial cells become more stretched, it will contract more. And when it contracts more, when there is more myocardial contractility, that means there will be more cardiac output, because more contraction means more stroke volume, and more stroke volume means more cardiac output, because as we know, cardiac output equal stroke volume divided by heart rate. So this is according to Frank-Starling law. The more you fill the heart with blood, the more it will contract. So that means if the preload is increased, this will result in more contraction by the myocardium, and so this will result in more production of cardiac output. So this is another way by which the sympathetic nervous system will maintain the cardiac output, by inducing venoconstriction, acting on the alpha adrenergic receptors on the veins. By causing venoconstriction, it will pump more blood to the heart. It will increase the venous return to the heart. And when the venous return to the heart is increased, this means the preload will increase. The volume of blood at the end of the diastolic phase will be more. And when there is more blood in the heart, there will be more stretching of the myocardial cells. And when the myocardial cells are stretched, it will contract more forcefully. And when it contracts more, it will produce more cardiac output. This is according to Frank-Starling law. You can think of that simply like the elastic rubber. If you have an elastic rubber, when you try to stretch the elastic rubber, and then when you stretch the elastic rubber, it will retract more forcefully. يعني لما تجيب الاستيكه العاديه، اي استيك، تشد الاستيك تفكه بيرجع بيعمل ريتراكشن، بيعمل صوت قوي. This is basically the same what happens in the myocardium. The more you fill it with blood, the more the myocardial cells will stretch out and the more it will contract. And so more contraction will produce more cardiac output. So this is according to Frank Starling law. So that means venoconstriction will result in more preload, and more preload will result in more cardiac output. So this again will compensate, and it will maintain adequate cardiac output in a patient with a failing heart. So this is another contribution by the sympathetic nervous system. Then also we have alpha adrenergic receptors on the arterial side, not only on the venous side, on the arterial sites as well. And on the arterial side, the sympathetic nervous system, by activating the alpha adrenergic receptors, it will lead to arterioconstriction. Constriction of the arterioles. And when the arterioles are constricted, that means the total peripheral resistance is increased, because the total peripheral resistance is mainly coming from the resistance at the level of the arterioles, because the arterioles are highly muscular vessels. And so when it constricts, this will increase the total peripheral resistance, which is also called the peripheral vascular resistance. And when there is increase in the total peripheral resistance, that means the blood pressure will increase, because the blood pressure equals cardiac output divided by the total peripheral resistance. So again, this is another mechanism by which sympathetic nervous system will correct the problem, which is low blood pressure. And main problem here, initial problem, is low blood pressure. Low blood pressure can be corrected by increasing the total peripheral resistance, by causing arterioconstriction, or it can be corrected by increasing the cardiac output. Well, increasing the cardiac output can be either due to direct effect of the sympathetic nervous system on the heart, increasing the heart rate and increasing the contractility, or it could be due to venoconstriction, which will lead to increase in the preload. Well, increasing the preload will lead to increase in the cardiac output. So we used the equation, which is blood pressure equal cardiac output divided by total peripheral resistance, to see how the sympathetic nervous system will correct the blood pressure in patients with a failing heart. So this is the contribution of the sympathetic nervous system. This is the neural part of the neurohumoral activation. The humoral part, it means hormones, different types of hormones, which will be released in response to drop in the blood pressure. The most important hormonal system is renin-angiotensin-aldosterone system. This will immediately become activated in patients with heart failure, and to remain activated for a long time. As long as the patient is having heart failure, the renin-angiotensin-aldosterone system will remain activated. What are the factors that lead to activation of this system? Number one, the sympathetic nervous system itself will activate the renin-angiotensin-aldosterone system. As we know, a renin-angiotensin-aldosterone system activation starts in the kidney. There are a group of cells called juxtaglomerular apparatus, and these cells are responsible for secretion of a hormone called renin. And then renin will act on a plasma proteins called angiotensinogen, which is produced by the liver. And angiotensinogen, by the action of renin, it will be converted into angiotensin 1. And then angiotensin 1 will be converted into angiotensin 2 within the pulmonary microcirculation by the action of enzyme called angiotensin converting enzyme. And then angiotensin 2 will act on the adrenal cortex, and it will stimulate the secretion of aldosterone by the adrenal cortex. This is how the renin-angiotensin-aldosterone system will be activated. One of the main factors that activate the renin-angiotensin-aldosterone system is sympathetic nervous system. So stimulation of the kidney by sympathetic nervous system will result in release of renin and will lead to activation of the renin-angiotensin-aldosterone system. This is one of the factors that result in activation of this system in heart failure. The second factor is renal hypoperfusion, because with heart failure, there is a drop in the cardiac output, there is a drop in the blood pressure. So that means there is renal hypoperfusion, because normally the kidneys receive around 20 to 25% of the total cardiac output. So logically, when the cardiac output drops, that means there will be less blood available for the kidneys. And so this will result in renal hypoperfusion. And renal hypoperfusion is one of the important factors that leads to activation of the renin-angiotensin-aldosterone system, because this system eventually will try to compensate, and it will try to increase the blood pressure. And so by increasing the blood pressure, it will improve the blood flow to the kidney. This is the aim of this system. So how can the renin-angiotensin-aldosterone system eventually correct the problems in heart failure, how it can maintain the cardiac output and correct the blood pressure? First of all, with the activation of the renin-angiotensin-aldosterone system, we will have high levels of angiotensin 2 in the blood, and we will have high levels of aldosterone in the blood. The high levels of angiotensin 2 in the blood will result in some beneficial effects because angiotensin 2 is a powerful vasoconstrictor. It's a hormone that leads to vasoconstriction. It acts on the renal vasculature and also in the blood vessels outside the kidney as well. And its effect is mainly on the arterial side, leading to arterioconstriction, similar to the sympathetic nervous system. So angiotensin 2 will produce effect similar to one of the effects of the sympathetic nervous system by inducing arterioconstriction. And when it induces arterioconstriction, it will increase the total peripheral resistance, and this will increase the cardiac output. So this is an important contribution. Then angiotensin 2 will act on the adrenal cortex and will stimulate the release of aldosterone, and this will result in hyperaldosteronism. And this is called secondary hyperaldosteronism. And aldosterone in high levels in the blood, as we discussed previously, will result in sodium and water retention by acting on the principal cells on the distal part of the nephron in the kidney. It will stimulate sodium and water retention. And more sodium and water retention will result in increase in the intravascular blood volume. And when there is an increase in the intravascular blood volume, basically that means there is more preload in the heart. When there is an increase in the blood volume, that means venous return to the heart will be more, and that means the preload in the heart will be more, because that means the volume of blood at the end of the diastolic phase will be more. And as I said, according to Frank's Starling law, increasing the preload will result in increase in the contraction by the myocardium, and this will result in increase in the cardiac output. So as you can see, aldosterone, by indirect way, eventually, it will result in increase in the cardiac output because it will increase the blood volume by causing sodium and water retention, and this will increase the preload, and increasing the preload will lead to more myocardial contractility, and more myocardial contractility means more stroke volume. More stroke volume means more cardiac output, and more cardiac output means more blood pressure. So this is the contribution of aldosterone in heart failure, and this is very important contribution. And that's why patients with heart failure, they tend to be chronically, they tend to be fluid overloaded. They tend to be hypervolemic. The extracellular fluid volume is increased in patients with heart failure. And this is secondary to the action of aldosterone here, because it keeps on retaining more and more salt and water in the body. So this is how the renin-angiotensin-aldosterone system will play a role as a compensatory system, compensatory mechanism in patients with heart failure. Then we have other hormonal factors. We have vasopressin system. Vasopressin means antidiuretic hormone. It's the same name for antidiuretic. It's another name for antidiuretic hormone, which is released by the posterior pituitary gland. It's produced and synthesized in the hypothalamus, and then stored in the posterior pituitary gland and released by the posterior pituitary gland. And antidiuretic hormone, it has two types of receptors. It has V1 receptors and it has V2 receptors. And V1 receptors are on the blood vessels. And by activating on the V1 receptors, it will lead to vasoconstriction. And so it can produce effects similar to the sympathetic nervous system and similar to angiotensin 2. But the most important action and the most pronounced action of ADH is on the kidney. On the kidney, on the principal cells of the kidney, in the collecting ducts, it has receptors called V2 receptors. By acting on V2 receptors, ADH will result in water reabsorption. It will lead to more water retention. And this will also increase the intravascular volume, similar to the action of aldosterone. And this eventually will increase the preload again, and this will increase the cardiac output. So ADH, again, plays an important role. And ADH, one of the important factors that stimulate the release of ADH is drop in the blood pressure. Whenever there is low blood pressure, ADH immediately will be secreted. And so because with heart failure, with the initial problem of heart failure, with the drop in the cardiac output that happens, there is a drop in the blood pressure, and this will immediately activate the vasopressin system. It will lead to release of ADH or vasopressin. Then there is another vasoconstrictor as well, which will be released by the vascular endothelium, and this is called endothelin. Endothelin is another hormone which acts as a vasoconstrictor also, similar to angiotensin 2. It acts mainly on the renal vasculature, but also it acts on other sites as well. And it will also lead to arterioconstriction. And so it will increase the total peripheral resistance, and this will increase the blood pressure. So in the hormones, which are included in the neurohumoral mechanisms, we have hormones that act like vasoconstrictors, like angiotensin 2, and like vasopressin, and like endothelin. And we have hormones that lead to water retention, like aldosterone and like vasopressin as well. So as you can see here, what happens with heart failure, there is reduced cardiac output. And this reduction in the cardiac output will result in a reduction in the blood pressure. And this will immediately activate the neurohumoral mechanisms, including the sympathetic nervous system, the renin-angiotensin aldosterone system, the vasopressin system, and endothelin system. The results of that is on two ways. Number one, يعني الvasoconstrictors will result in arterioconstriction, vasoconstriction, specifically arterioconstriction, and this arterioconstriction will increase the total peripheral resistance. Increase in the total peripheral resistance basically means increased afterload. And this is another important term. It's different than preload. Preload is a volume. It's a volume of blood at the end of the diastolic phase. It's an end-diastolic volume. This is the preload. While afterload is a pressure. It's not a volume. It's a pressure. And it's a pressure of blood within the ventricles during the systolic phase. يعني the pressure in the ventricles during the systolic phase, when the ventricle is contracting, this is called afterload. And whenever the total peripheral resistance is increased, immediately the afterload will increase, because when there is increase in the total peripheral resistance due to arterioconstriction, this is classically seen in hypertension. With hypertension, there is arterioconstriction. There is increase in the total peripheral resistance with hypertension. When there is increase in the total peripheral resistance, the pressure inside the ventricle during the systolic phase will be elevated. And this is afterload. And basically means it's the pressure that has to be generated by the ventricle during the systolic phase in order to open the aortic valve. Yani in order for the aortic valve to open, and in order for blood to pass and to move forward from the left ventricle to the systemic circulation, the left ventricle must generate adequate pressure that will overcome the total peripheral resistance. And this pressure, which will be generated during the systolic phase, is called the afterload. And it's proportional and directly proportional to the total peripheral resistance. So كل ما زاد the total peripheral resistance, that means there is increased afterload in the heart. So that means vasoconstriction or arterioconstriction will result in increased afterload. While on the other side, aldosterone will vasopressin together will lead to water retention, sodium and water retention, and this sodium and water retention will lead to increase in intravascular volume. And increasing the intravascular volume will lead to increase in the preload. So that means in a neurohumoral activation will result in increase in both preload and afterload. This increase in preload and afterload initially is beneficial, because an increase in preload means في more contraction by Frank-Starling law, and this means في more cardiac output. This is beneficial. And increase in the afterload means there is increased total peripheral resistance, which this means the blood pressure is increased, because the blood pressure equals the cardiac output divided by total peripheral resistance. So for a long time, this increase in preload and increase in the afterload is actually beneficial to the failing heart, because it will maintain the cardiac output and it will maintain the blood pressure. But after a long time, after several years, this excessive increase in the preload and excessive increase in the afterload will have negative impact on the heart. It will have negative impact on the myocardium. Because when you increase the preload, that means the heart has to work on more blood volume. That means there is an extra load of blood present at the end of the diastolic phase. And that means in the next systolic phase, the heart has to work on extra load of blood. So it has to work more. So there is an increased cardiac work. There is an increased strain on the heart. And when there is increased afterload, this increase in the afterload basically means there is resistance in the systemic circulation. So that means the heart has to work harder and has to work more in order to overcome this resistance, in order to generate higher pressure to overcome the resistance at the level of the arterioles, which is generated by sympathetic nervous system and generated by vasoconstrictors. And so that means there is the end result of increased preload and increased afterload is increased cardiac work. The cardiac workload will be increased. And when the heart, and in patients with chronic heart failure, this situation will be for a long time. It will be for many years. For many years, the heart is working more in order to handle this high preload and in order to handle this high afterload. Eventually, this increased cardiac work will apply strain on the heart, on the myocardium, and this will trigger the development of cardiac remodeling. It will result in structural and functional changes on the myocardium. And these structural and functional changes include, first of all, when we talk about the structural changes in the myocardium, there is loss of myocytes. Myocytes will start dying. It will die either by apoptosis, programmed cell death, or by necrosis. There is myocardial cell death by necrosis or by apoptosis. This is part of the structural changes that happen with cardiac remodeling. The second problem is there is also alteration in the extracellular matrix in the myocardium in form of fibrosis. So there is myocardial interstitial fibrosis. Yani not only there is myocardial cell necrosis and apoptosis, but also there is myocardial interstitial fibrosis as part of the structural changes with cardiac remodeling. Then in the functional changes, some of the myocytes structurally might appear normal, but it will be functionally abnormal. It will not function normally. It will not contract normally, although it's structurally appearing normal, but it will not contract normally. And these myocytes that are functionally abnormal, these myocytes will have altered and abnormal gene expression. They will start expressing proteins that are normally not found in the healthy heart. They will start proteins that are normally detected in the fetal heart. They will express more fetal proteins instead of expressing and producing normal contractile proteins. So instead of producing normal contractile proteins, they will start producing some abnormal proteins that are normally found in the fetal heart. So these proteins are useless in adult healthy heart. And so that means myocytes that are even appearing structurally normal, they will be functionally abnormal due to abnormal gene expression. And also as part of the structural changes, the myocytes and the myocardial cells will undergo hypertrophy to become thicker. And this is not a physiological hypertrophy, myocardial hypertrophy that is seen with athletes. This is a pathological hypertrophy, pathological myocardial hypertrophy. And this is part of the remodeling changes as well. So cardiac remodeling will include structural and functional changes. Structural changes will include myocardial cell death by necrosis and by apoptosis, to include myocardial interstitial fibrosis, to include myocardial hypertrophy. While functional changes is abnormal gene expression, including expression of fetal proteins. So together, these structural and functional changes happening in the myocardium, it will result in worsening of the cardiac function. You can imagine if the myocardium is losing more myocytes by necrosis and apoptosis, the number of myocytes are reducing. And at the same time, there is fibrosis. And at the same time, the myocytes that are structurally normal, they are not functioning normally. They are not contracting due to abnormal gene expression. So you can imagine that this myocardium will have less contraction, to contract less. And so that means eventually this will lead to worsening of heart failure and will lead to worsening of the cardiac output and worsening of the blood pressure. So as you can see, for many years, these neurohumoral activations, neurohumoral mechanisms, sympathetic nervous system, along with several hormones, for many years, they are maintaining adequate cardiac output by several mechanisms, as we discussed. But on long-standing cases, after several years, eventually, these neurohumoral mechanisms will have negative impact on the heart and it will result in cardiac remodeling. And this cardiac remodeling will lead to more myocyte loss, it will lead to more myocardial fibrosis, and eventually it will lead to worsening of heart failure, and it will lead to worsening of the cardiac output and drop in the blood pressure. And when there is drop in the blood pressure, again, there will be more activation of neurohumoral mechanisms. And when it becomes more activated, again, it will lead to similar problem. It will lead to more cardiac remodeling. And more cardiac remodeling will lead again to worsening of heart failure, and worsening of heart failure will lead to more activation of neurohumoral systems. And so basically we will end up with a vicious cycle which will not end unless we interfere with the specific treatment strategies which will control these negative effects of the neurohumoral mechanisms. So that means chronic heart failure, once it starts, it tends to progress over years. As you can see, it's a circle, or it's a cycle. It's a vicious cycle. So that's why it's important to understand the pathophysiology of heart failure, because it will tell us what are our aims in the management of heart failure, and what specific drugs to use, and how these drugs eventually can help to control heart failure, because the drugs will act on this picture, especially the drugs that reduce the mortality. The drugs in the management of heart failure, the anti-failure drugs, will act on the pathophysiology of heart failure. For example, when we give diuretics, when we give loop diuretics, furosemide, in patients with heart failure, furosemide is known to improve the symptoms in heart failure. It's known to improve the congestive symptoms of heart failure, like symptoms related to pulmonary venous congestion and pulmonary edema. And the action of furosemide is by inducing natriuresis, and so it will induce diuresis to lead to more renal and urinary excretion of free water, and excretion of sodium as well. And this will act here. It will reduce the sodium and water retention, and so it will reduce the intravascular volume. When we give diuretics, we will reduce the intravascular volume. And when we reduce the intravascular volume, we will reduce the load on the heart. We will reduce the preload. And this reduction in the preload will help in controlling the symptoms. Because an increase in the preload, an excessive increase in the preload, is what will lead to increase in the ventricular filling pressure that we mentioned in our definition. We said that in heart failure is defined as clinical syndrome that develops when the heart is unable to pump adequate output, or able to do so by elevated filling pressure. And elevated filling pressure is coming from this elevated preload. When we increase the preload, when we increase the volume of blood during the diastolic phase in the heart, that means pressure during the diastolic phase will become high. And this pressure during the diastolic phase is called the filling pressure. And when the filling pressure is high in the left side of the heart, that means pulmonary veins that normally supposed to drain into the left side of the heart, the pulmonary veins now will not be able to empty the blood completely into the left side of the heart, and the pressure is very high in the left side of the heart. And so blood will become congested in the pulmonary veins, and the pulmonary venous pressure will increase. And this pressure will be transmitted backward to the pulmonary capillaries. And the capillaries are thin-walled. They are not like the arteries and veins. They are thin-walled. And so when the pressure is increased in the pulmonary capillaries, the fluid will start leaking. The plasma fluid will start leaking outside the capillaries into the pulmonary interstitium, and then into the intra-alveolar spaces, resulting in pulmonary edema. So that means clinical features of congestive manifestations in heart failure are coming from the increased ventricular filling pressure. And this increase in the ventricular filling pressure is due to increased preload that is seen as a compensatory mechanism in patients with heart failure, with chronic heart failure. And so during our management, we will try to reduce this preload. We can reduce the preload by giving diuretics, like loop diuretics, which will reduce the intravascular volume, and this will reduce the preload. And when we reduce the preload, we reduce the filling pressure. And when we reduce the filling pressure, we will reduce the pulmonary venous congestion and pulmonary edema. And so this will provide symptomatic relief to the patient. Then also, as part of the management of heart failure, we can give vasodilators, like ACE inhibitors, like hydralazine and nitrates in combination, sometimes given. Vasodilators will act here on this side, one of its actions. It will counteract the vasoconstriction. And by counteracting vasoconstriction leading to more vasodilatation, it will reduce the afterload. And by reducing the afterload, again, it will relax the heart. The heart now has to work against less afterload, against less total peripheral resistance because there is vasodilatation. And this eventually can help to reduce myocardial remodeling, because when you reduce the cardiac workload, eventually this will reduce the cardiac remodeling, because the cardiac remodeling is coming from this increased strain on the heart, this increased cardiac workload by the high preload and high afterload. And so when we give ACE inhibitors, drugs like lisinopril, this group of drugs shown to have prognostic benefits. They are shown to reduce the mortality in the management of heart failure, because one of its action, it will reduce the afterload. And by reducing the afterload, it will relax the myocardium to reduce the cardiac workload. And by reducing the cardiac work, this will reduce cardiac remodeling. And so that's why it reduces the mortality in patients with chronic heart failure. Then also, these cardiac remodeling changes are also directly related to the action of angiotensin II and aldosterone. And angiotensin II and aldosterone together, they were found to have direct effect on cardiac remodeling. They directly act on the heart, and they result in changes associated with cardiac remodeling. And so for that reason, it's very important in our management strategies to block the action of angiotensin II and the action of aldosterone on the heart. And we can do so by giving drugs like angiotensin converting enzyme inhibitors, like ACE inhibitors, and also like spironolactone, which is aldosterone antagonist. These drugs will block the action of aldosterone on the heart, and so they will reduce the cardiac remodeling associated due to the direct effect of aldosterone on the myocardium. And aldosterone and angiotensin II together, they have pro-fibrotic effect on the myocardium. They will induce myocardial fibrosis, as I said here, which is part of the cardiac remodeling. The human body is organized in a way that if there is specific system associated with negative effects on the heart or in any organ, at the same time, there will be another system which has opposing action. هنا in heart failure, we have a neurohumoral mechanisms that we discussed here: sympathetic nervous system, renin, angiotensin, aldosterone system, vasopressin, endothelin. We said that these neurohumoral factors, on the long run, they will have negative impact on the heart. And so on the other side, we have other hormones which will counteract the action and the effect of these hormones, that will act against these hormones in order to lessen and to reduce a negative impact of these hormones and this sympathetic nervous system on the heart. The other systems are vasodilators. الفازوكونستريكتors هم الانجيوتنسين 2 والاندوثيلين والفازوبريسر وهم what will lead eventually to cardiac remodeling. But at the same time, whenever there is heart failure, there is also a system of vasodilating hormones which will be activated and will be released. These vasodilators include natriuretic peptides, AMP and BMP. We have atrial natriuretic peptide released from the atrium, and we have the BMP, the B-type natriuretic peptide. It's called brain natriuretic peptide, but actually it's produced from the ventricular myocardium. And then we have other vasodilators like bradykinin and like nitric oxide. The levels of these vasodilators will increase with heart failure, especially a natriuretic peptides, AMP or BMP. AMP or BMP, these are immediately released whenever there is strain on the myocardium. Whenever there is a strain, any damage to the myocardium, whatever the underlying damage, it will immediately result in release of AMP from the atrium myocardium and BMP from the ventricular myocardium. So basically now myocardium, the heart, is acting like an endocrine organ. It's producing and releasing hormones into the blood. And AMP or BMP, these are very important in counteracting the action of the vasoconstrictors, like angiotensin II and like endothelin. Because natriuretic peptides, they are called natriuretic peptides, first of all, because they induce natriuresis. They lead to natriuresis. They will lead to urinary sodium excretion, more sodium excretion through the urine. And with more sodium excretion, you will have more water excretion, because water will always follow sodium. And so that means natriuretic peptides, the AMP or BMP, they have an endogenous and natural diuretic effect. These are like natural diuretics present inside our blood. And this is a way by which the heart is trying to reduce the load. Yani the heart, in heart failure, the heart is under volume overload because there is excessive preload coming to the heart. So the heart is under volume overload. So yani one way by which the heart is trying to reduce this volume overload, to reduce this preload, is by releasing these natriuretic peptides, which will offload the patient. It will lead to more loss of water through the urine. And so it will slightly reduce the intravascular volume. And so it will reduce the preload. You've got this system, as you can see, a natriuretic peptide is acting against the system. And so it has protective effects. And these natriuretic peptides, they are not just acting like diuretics, they also act like vasodilators. They act on this side, they reduce intravascular volume, and so they reduce the preload. But at the same time, they act like vasodilators. They induce vasodilatation. So they counteract a vasoconstricting effect of angiotensin II and endothelin. And by acting like vasodilators, they will reduce the afterload. And by reducing the afterload, again, they will reduce the pressure load on the heart. In heart failure, the heart is under volume overload and under pressure overload at the same time. The volume overload is coming from the excessive preload, and pressure overload is coming from the excessive afterload. And both are reduced by the natriuretic peptides, AMP or BMP. So you can see these hormones are playing a very important role in patients with heart failure. And so for that reason, nowadays, there is a group of drugs developed and used in the management of heart failure called neprilysin inhibitors. Neprilysin inhibitors, we have only one drug now available called sacubitril. Sacubitril, which is neprilysin inhibitor, is a drug which will inhibit an enzyme called neprilysin. And neprilysin enzyme, it's an enzyme that results in degradation, and it leads to breaks down of the natriuretic peptide. So when you give an enzyme that inhibit neprilysin, when you give a drug that inhibit neprilysin enzyme, this will lead to less breakdown of natriuretic peptides. And so this will increase the half-life of natriuretic peptides in the blood. And this is beneficial to patients with heart failure. We want more natriuretic peptide in patients with heart failure because these endogenous hormones will lead to less preload, it will reduce the preload, and it will reduce the afterload, and this will help to relax the heart, and this will help to reduce the cardiac workload, and this will reduce cardiac remodeling. And so these drugs are also shown to have mortality benefits. They reduce mortality because they act on the cardiac remodeling by increasing the action of natriuretic peptides. And neprilysin inhibitor, sacubitril, is not used alone in the management of heart failure, according to the guidelines. It's given in combination with angiotensin receptor blocker, which is valsartan. And we have sacubitril valsartan combination. And this combination, according to trials, was found to have prognostic benefit in patients with heart failure. It reduced mortality. This combination is called ARNI, A-R-N-I. ARNI stands for, AR stands for angiotensin receptor. An NI stands for neprilysin inhibitor. So angiotensin receptor blocker combined with neprilysin inhibitor, this is called ARNI. And this combination is beneficial in heart failure, is used to reduce mortality in patients with heart failure. In this slide, these two pictures, we can see the relationship between the preload and the cardiac output, because this is a very important concept as we discuss in the pathophysiology. As we said, according to Frank-Starling law, increasing the preload will lead to increasing the cardiac output, because increasing the preload will lead to more stretching of the myocardial cells. And when the myocardial cells are more stretched, it will contract more. And more contraction means more cardiac output. But this should be within physiological limits, because again, the heart can tolerate increasing the preload to a specific limit. But eventually, when there is too much preload, when there is excessive preload and becoming above the physiological limits of the heart, then you will have a paradoxical effect. a normal effect according to Frank-Starling law ان احنا لما نزيد البريلود المفروض يزيد الكونتراكشن وبالتالي يزيد الكارديك اوتبوت. لكن اذا كان البريلود excessive and above the physiological limit of the heart, it will have a reverse effect. At that point, the preload will reduce the contraction of the heart, and so it will reduce the cardiac output. because when يكون في too much preload above the physiological capacity of the heart, it will result in overstretching of the myocardial cells. And myocardial cells, when it becomes stretched within physiological limit, it will contract more. لكن if it's overstretched أكتر من اللازم, it will become dilated. And when it becomes dilated myocardium will contract poorly. And so that means this will result in less cardiac output. So as you can see هنا في compensatory mechanisms, initially a sodium and water retention and increasing intravascular volume was doing good work. It was increasing the cardiac output and increasing the blood pressure, maintaining the cardiac output and maintaining the blood pressure for a long time. But eventually, this excessive buildup of preload will exceed the physiological capacity of the heart, and so it will have a negative and reverse effect. Instead of increasing contraction, it will reduce contraction because it will lead to dilatation. You can imagine if you have a chamber which is overfilled with fluid, overfilled with blood, this is the preload. Eventually, this chamber will become dilated. And when it becomes dilated, it will become less contractile. This is a very important concept. And actually, the end result of this cardiac remodeling, when this cardiac remodeling happens in patients with heart failure due to structural and functional changes in the heart, as the time goes by, the ability of the heart to handle the preload will become less and less. لأنه هنا الهارت with cardiac remodeling, the heart is losing more myocytes. There are more functionally abnormal myocytes, which will not be able to contract the blood, to inject blood. And so eventually, this cardiac remodeling will lead to more dilatation of the heart, to lead to myocardial ventricular dilatation. And eventually, the heart will become dilated. And when it becomes dilated, even you can, at that point, when you do physical examination, you will detect an apex beat, which is displaced outside the mid-clavicular line and displaced even beyond the fifth intercostal space. And on chest X-ray, you will be able to detect cardiomegaly. So the detection of cardiomegaly a lot of times tend to be very late. Finding in patients with heart failure, it indicates the heart now underwent a lot of remodeling changes, which eventually led to dilatation of the heart, of the ventricular chambers. And this dilatation of the ventricular chambers is secondary to the excessive preload, which is overfilling the heart, and the myocardium, because it's diseased and it's having a lot of remodeling changes, unable to deal with this extra load of preload, with this extra load of blood. So الفرانك ستارلينج لو بيقول انه كل ما زدنا البريلود كل ما هيزيد الكونتراكشن كل ما هيزيد الكارديك output. But eventually, if the preload exceeded the physiological capacity of the heart, this preload will result in dilatation of the heart, and dilated myocardium will become less contractile. Dilated myocardium is hypocontractile, and so this will reduce the cardiac output. So as you can see here in this figure here, this is a normal. In the line A, this is a normal response in a normal heart, normal healthy heart. As you can see, whenever you increase the preload, the cardiac output will increase. And the line is going like that. But then after that, the patient developed heart failure. And with heart failure, gradually, the ability of the heart to deal with the preload will be less. And so as you can see, the line will be deviated more to the right, and it's becoming more flat. So that means الزيادة في preload after that, when the patient develops heart failure over many years, الزيادة في preload will be accompanied by less cardiac output in B. And then in C, after several years, again, the preload is increasing, but the cardiac output is not as increased as before. Until here, D, the line, if you can see here, the line is becoming more flat compared to C and B. And that means, despite preload is increasing, preload is horizontal here, preload is increasing, but the cardiac output is not responding. There is no significant rise in the cardiac output. And eventually it will become totally flat, in which the preload is increasing, but the cardiac output is not increasing at all. As you can see here also in this picture, this is the end-diastolic volume. And end-diastolic volume هو نفسه البريلود. Preload is equal to the end-diastolic volume, because by definition, preload is the volume of blood present at the end of the diastolic phase. So the end-diastolic volume is the preload. And this is stroke volume. And stroke volume it can be also considered similar to the cardiac output. The cardiac output dependent on the stroke volume. As we know, cardiac output equals stroke volume divided by heart rate. So when the preload increases, when the end-diastolic volume increases within physiological limits, the contraction will increase and the stroke volume will increase. And the increase in the stroke volume will lead to increase in the cardiac output. This is the normal, as you can see here. Normally, a normal end-diastolic volume or normal preload in an average healthy male is around 120 ml. يعني the volume of blood which is present in the ventricles at the end of the diastolic phase is around 120 ml in an average healthy male patient, healthy male individual. And normally, the heart will be able to eject around 70 ml out of this 120 ml per each beat. Yani, as we know now, we have a concept of ejection fraction, which is the fraction or the percentage of blood ejected with the heartbeat, with each beat. Ejection fraction is not 100%. Yani, not all the volume of blood which is present during the diastolic phase will be ejected by the heart. The ejection fraction is around 50% plus or minus 5. This is the normal ejection fraction. فهنا approximately here in normal healthy patient, in normal healthy individuals, out of the 120 ml of the end-diastolic volume, which is the normal end-diastolic volume, 70 ml will be ejected out. And this is almost 60% يعني, of the 120 ml. So the ejection fraction here is around 60%. And this is normal ejection fraction. This is a normal healthy heart. And as you can see, if you keep on increasing the end-diastolic volume and when you keep on increasing the preload, the stroke volume will keep on increasing. As you can see, this is normal response according to Frank Starling law. When you increase the preload, the contractility will increase and so the stroke volume will increase. But in heart failure, eventually, as I said, because the preload is increasing significantly and it's exceeding the physiological limits of the heart, and at the same time, the heart is getting يعني, more and more يعني, with a lot of changes, cardiac remodeling, eventually, increasing the preload will actually, it will be followed by a reduction in stroke volume. As you can see, the line, it will drop after that, to start dropping. So then the increase in the end-diastolic volume beyond the physiological limit will be associated with paradoxical effect or reverse effect. Instead of increasing stroke volume, it will actually reduce the stroke volume because the contractility now is becoming less. So these are what we discussed so far, and neurohumoral compensatory mechanisms. It include sympathetic nervous system activation, renin-angiotensin-aldosterone system activation, ADH or vasopressin system, endothelial system. And on the other side, we have the natriuretic peptides, AMP and BMP. They are acting against other systems. Then we have the cardiac remodeling changes that develop eventually. These are structural and functional changes, as we said. We have loss of myocytes by apoptosis and focal necrosis. We have interstitial fibrosis. We have ventricular hypertrophy and abnormal gene expression. All these changes together are called cardiac remodeling. And eventually, this cardiac remodeling will make the heart more and more dilated. And this will result in cardiomegaly in patients with heart failure. And dilated heart is associated with impaired contractility. Whenever the heart is dilated, that means a contraction of the heart will be less and less. And with impaired contractility, the cardiac output will be less. And when the cardiac output is less, there will be more activation of neurohumoral compensatory mechanisms. And more activation of neurohumoral compensatory mechanism will lead to more cardiac remodeling. And more cardiac remodeling will lead to more cardiac dilatation. And this will result in worsening of cardiac output again. And so it's like a vicious cycle. It will keep on circling like that. الكلام ده واضح يا جماعه؟ في سؤال بخصوص الباثوفيسيولوجي، هو اور مين يعني توبيك في during our lecture، بيحتمل عليه الكلام هنقوله من
واضح جدا والله يا بس.
اوكي تمام. في اي question، اي سؤال قبل ما to go to the next section؟
لا.
Okay. So next, we will talk about the classifications of heart failure. In general, heart failure is classified in multiple ways. There are multiple classifications. There are traditional classifications that we know, and these are mainly clinical classification into left heart failure, right heart failure, or biventricular failure. And we have also classification according to the onset into acute or chronic heart failure. And also we have, according to the cardiac output, we have low output heart failure, we have high output heart failure. But all these are old and traditional classifications. The modern classification of heart failure is according to the ejection fraction. This is how it's supposed to be classified nowadays, according to the ejection fraction. And according to the ejection fraction, with the NICE guidelines, there are two main categories. We have heart failure with reduced ejection fraction, and we have heart failure with preserved ejection fraction. And heart failure with reduced ejection fraction, by definition, these are the cases of heart failure where the ejection fraction is 40% or less. While heart failure with preserved ejection fraction, these are the situations where the patient is having heart failure despite normal ejection fraction. And by definition, the ejection fraction should be 50% or more, according to the NICE guidelines. So as you can see, في gap, ejection fraction between 41 to 49. Here it's not defined according to NICE. And NICE only defines heart failure with ejection fraction 40% or less, and this is called heart failure with reduced ejection fraction. And heart failure with ejection fraction 50% or more, this is called heart failure with preserved ejection fraction. The European Society of Cardiology, they added a term to those patients who are having heart failure with ejection fraction between 41 to 49. أكثر من الهارت failure of reduced ejection fraction وأقل من heart failure of preserved ejection fraction. And the term used here is heart failure with mildly reduced ejection fraction. بالتالي مثلا European guidelines, European Society of Cardiology, they have three types of heart failure. Number one, heart failure with reduced ejection fraction, هنا ejection fraction 40% or less. Number two, they have heart failure with mildly reduced ejection fraction. وهنا ejection fraction between 41 to 49%. And then they have the third category, which is heart failure with preserved ejection fraction, which is ejection fraction 50% or more. So this is the modern classification of heart failure. Previously, heart failure with reduced ejection fraction, previously it was called, في old classifications, it was called systolic heart failure. Because لما يكون الهارت failure معاه reduced ejection fraction, هنا البروبلم معناته systolic function of the heart. The heart is not pumping adequate blood. It's not producing adequate cardiac output due to a systolic function of the heart, due to a contraction of the heart. This is a problem related to the contractility of the myocardium. While a heart failure with preserved ejection fraction, previously it was called diastolic heart failure, to indicate that a problem is not the systolic function of the heart. It indicates a contractile function of the heart is intact, is normal. But the problem is in the diastolic function of the heart, a relaxation of the ventricular chambers during a diastolic phase. المفروض the ventricular chambers to become relaxed completely, to be filled with blood during a diastolic phase, in order to contract after that during the systolic phase. At diastolic heart failure, it indicates a problem is not in the systolic function. The heart is contracting normally, producing adequate ejection fraction, but the problem is in the filling of the ventricles during the diastolic phase. Ventricles will not relax enough to be filled completely with blood. This was called diastolic heart failure, but now it's called heart failure with preserved ejection fraction. Then we have the New York Heart Association classification. This is more of a functional classification. This is used to assess the severity of the clinical condition of the patient. It's mainly focusing on the left heart failure, where the patient is having pulmonary manifestations of pulmonary venous congestion, like exertion dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and eventually these patients can present with dyspnea even at rest. According to that, it has 4 classes: NYHA class 1, 2, 3, and 4. In class 1, there is no limitation to the physical activity. And no limitation of physical activity basically means the patient can do ordinary physical activities without producing any symptoms. The patient is not having any exertion-related congestive symptoms with ordinary physical activity. This is called class 1. Class 2, it means there is slight limitation of physical activity. And that means هنا the patient is comfortable at rest. As long as the patient is at rest, will not have any symptoms. But the ordinary activity results in symptoms. يعني ordinary activity that يعني were carried normally by the patient before, now the patient will have trouble doing these ordinary activities. And the patient will develop symptoms with these ordinary activities. But when the patient is at rest, the patient will be asymptomatic. This is called class 2 NYHA. Class 3 NYHA, there is marked limitation of physical activity. So that means here, the patient again is comfortable at rest still, but here less than ordinary activity results in symptoms. يعني the patient even with simple activities can develop symptoms. For example, يعني simply by يعني moving, getting up from the bed and going to the bathroom can precipitate symptoms. This is less than ordinary activity. This is class 3. Class 4, this is the extreme form, and this indicates usually in the stage disease in which the patient is unable to carry out any physical activity at all without discomfort. يعني any sort of physical activity, whatever it is, it will immediately precipitate symptoms of heart failure. And in this category also, the symptoms are even present at rest. And this is the main distinguishing point between class 4 and the other classes. With class 4, the symptoms of heart failure are even present at rest. It does not need any exertion to be precipitated. So this is called NYHA classification. We should not depend on this classification in the diagnosis of heart failure. This is just a classification that is used. It's a functional classification that assesses the severity of the clinical condition. But the diagnosis should be according to this classification, according to the ejection fraction. When you put the diagnosis of heart failure, you should be able to differentiate whether this is heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, or heart failure with preserved ejection fraction. Because there are some differences in the management that we will talk about it later. So the old classification of heart failure was clinical. Until now, we use it. And it's according to which side of the heart predominantly affected. Is it the left side, or is it the right side, or is it both? So we can have either left heart failure or left ventricular failure, right heart failure or right ventricular failure. And we have biventricular failure in which both ventricles are failing. So let's try to discuss these three types. When we talk about left heart failure, it means the problem is localized to the left side of the heart. For example, it could be myocardial infarction, or it could be valvular heart disease affecting the valves on the right side, on the left side of the heart. For example, mitral regurgitation or aortic stenosis. So whatever the underlying cause, whenever there is left heart failure, it means there is reduction in the left ventricular output by definition. Whenever there is reduction in the left ventricular output, as you can see here in this figure, this is a simple figure showing a circulatory system in the body. This is the left side of the heart in red, as you can see, because this is the right side of the heart, as you can see. The left side of the heart has the left ventricle here and has the left atrium here. It's very clear. Normally, the left side of the heart ejects the blood through the aortic valve into the systemic circulation, as you can see. This is systemic circulation. And then the blood from the systemic circulation, it will return back to the right side of the heart through the caval system, as you can see. This is the caval system. This is systemic circulation to the upper limbs and to the lower limbs, and then through the caval system, it will return to the right side of the heart. What happens in left heart failure, there is a reduction in the left ventricular output. So the left ventricle is producing less output into the systemic circulation. When there is less blood is ejected into systemic circulation, basically that means more blood will be left behind in the ventricular chamber. If less blood is going out, more blood will be left here. And when there is more blood here, that means during the diastolic phase, and during the next diastolic phase, the heart here, the left ventricle here will have more load of blood. So the preload is high. Or the end-diastolic volume, again the preload هو نفسه end-diastolic volume. أما يكون في less ejection of blood during the systolic phase due to left ventricular failure, that means هيكون في more blood left here in the next diastolic phase. And so that means an end-diastolic volume will go up here. And when there is increase in the end-diastolic volume here, as we discussed previously, that means there is increase in the filling pressure. There's increase in the pressure here in the left ventricle. So immediately, when there is left ventricular output, when there is reduction in the left ventricular output, this will immediately increase the volume and pressure here in the left ventricular chamber. If the pressure here is high, that means the left atrium will not be able to pump and to empty the blood completely into the left ventricle because the pressure here is so high. And so for that reason, more blood will be retained here in the left atrium. And when there is more blood retained here in the left atrium, the pressure also will go up here. You will have increased intra-atrial pressure. So initially, we're going to increase intraventricular pressure, which will lead to increased intra-atrial pressure. If the pressure here in the left atrium is high, that means the pulmonary veins here, the pulmonary veins which are normally supposed to drain and supposed to empty the blood into the left atrium, the pulmonary veins will not be able to empty the blood completely into the left atrium because the pressure here is too much. And so that means more blood will be retained in the pulmonary venous circulation, and this will result in pulmonary venous congestion. So the pulmonary veins here will become congested, and the pressure here in the pulmonary veins will again go up. So reduction in the left ventricular output will result in increase in the left ventricular pressure. Increase in the left ventricular pressure will result in increase in the left atrial pressure. Increase in the left atrial pressure will result in increase in the pulmonary venous pressure. This increase in the pulmonary venous pressure will go backward, and it will affect the pulmonary capillaries because the pulmonary veins, pulmonary veins connected with the pulmonary capillaries here. Capillaries, unlike the veins and unlike the arteries, they are thin-walled. They have a very thin wall. And so pressure من يزيد هنا في الpulmonary veins, that means the pressure here in the pulmonary capillaries will also increase. And when the pressure increases in the pulmonary capillaries, unlike the veins, unlike the cardiac chambers, it's thin-walled, and so immediately the fluid will start leaking due to high pressure, due to high hydrostatic pressure in the capillaries. The plasma fluid will start leaking from the intravascular space into the extravascular space. And in the extravascular space, initially it will accumulate in the interstitium of the lung, resulting in pulmonary interstitial edema. And then it will even start accumulating inside the alveolar sacs, resulting in pulmonary intraalveolar edema. And so that means the end result is pulmonary edema, as you can see. And this pulmonary edema, when there is pulmonary edema, the lungs will become heavy and boggy. The lungs, when it becomes filled with fluid, and when there is more congestion of blood in the pulmonary veins, and there is buildup of fluids within the lungs due to pulmonary edema, the lungs will start to become heavy. And so that means in the respiratory muscles, it will require an extra effort in order to expand the lung. And the lung now will become less compliant due to fluid accumulating in the lungs. And so the muscles has to work more to expand the lung. And this increased respiratory efforts by the respiratory muscles, will precipitate the clinical presentation associated with pulmonary congestion, which is breathlessness, dyspnea. So dyspnea that develops in these patients with left heart failure are basically related to the reduced lung compliance and the attempt of the respiratory muscles to expand the heavy lung, the lungs which are heavy by the congested blood vessels and by the accumulating pulmonary edema. So these are the clinical features in patients with heart failure, with left heart failure. And in these patients, symptoms classically tends to be worse with exertion, because with exertion, the muscular contraction in the lower limbs with exertion will result in more constriction of the veins in the lower limbs. The veins in the lower limbs will become more constricted with contraction of the muscles in the lower limbs. And when these veins are constricted, it will push, and it will push more blood with the venous return to the heart. And so more blood will arrive to the right side of the heart, and then from the right side of the heart, it will go to the left side of the heart. And that means when the blood is increasing, when there is more blood is being pushed from the venous system into the right side of the heart, the blood will flow from the right side, through the cavern system, it will enter the right ventricle. And from the right ventricle, it will enter the pulmonary artery. The pulmonary artery will send the blood into the capillaries, and eventually the blood from the capillaries is supposed to go to the pulmonary veins, and then from the pulmonary veins into the left atrium, and then to the left ventricle. This is the normal response. But in patients with a failing heart, remember, the pressure here is high, the pressure here is high, and the pressure here is high, and also in the capillaries, the pressure is high. So this extra blood which is coming from the muscular pump with exercise, it will not be emptied properly into the left side of the heart due to very high pressure. And so this blood will be congested here because pulmonary veins cannot empty into the left atrium due to high pressure in the left atrium. The left atrium cannot empty into the left ventricle completely due to high pressure in the left ventricle. So this will result in back pressure and will lead to more congestion of blood here within the pulmonary venous system, within the pulmonary veins. And this will lead to more pressure in the pulmonary capillaries, and this will lead to more edema. And so with exercise, these patients, they tend to develop worsening symptoms. And this is classically called exertion dyspnea. These are some basic concepts in heart failure. The degree and the severity of pulmonary edema will depend on the onset of left heart failure, whether it's acute or chronic. As we know, heart failure can be either acute heart failure or it can be chronic heart failure. And left heart failure itself can be either acute or it can be chronic left heart failure. With acute heart failure, the symptoms tend to be more severe, as we know. The patient tends to present with frank pulmonary edema. The patient will have severe breathlessness even at rest. While patients with chronic heart failure, they tend to have less pulmonary edema, or even they might be protected from pulmonary edema. They might not have pulmonary edema at all, but their main problem is pulmonary venous congestion. Pulmonary veins are congested, lakin not to the extent of causing pulmonary edema, or there is minimal pulmonary edema. So let's see why patients with acute heart failure, they tend to have more pulmonary edema compared to patients with chronic heart failure. With acute heart failure, there is sudden drop in the cardiac output in the left ventricle. There's an underlying condition, for example, acute myocardial infarction or acute valvular regurgitation with infective endocarditis, for example, which will lead to sudden drop in the left ventricular output. This sudden drop in the left ventricular output will result in rapid rise in the left ventricular pressure and rapid rise in the left atrial pressure. And this rapid rise in the left atrial pressure will be transmitted backward to the pulmonary veins and into the pulmonary capillaries. So the pressure in the pulmonary capillaries will be very high, and it will lead to excessive pulmonary edema. And the degree of edema formation will be more and faster than the degree of absorption of the edema by the lymphatics, because the edema fluids are normally absorbed by the lymphatic system. But here, because the pressure is very high here in the atria and in the ventricles, the pressure will build up rapidly in the pulmonary venous system and in the pulmonary capillaries. And so the production of edema is faster than the drainage of edema fluid by the lymphatics, and so the patient will end up with frank pulmonary edema, with severe pulmonary edema. But in chronic heart failure, the underlying condition will develop gradually. The condition will develop gradually, and there are activated neurohumoral mechanisms, as we discussed previously. And activated neurohumoral mechanisms, as we discussed previously, it will result in increasing the preload, which will gradually dilate the ventricular chambers. An increased preload that happens with chronic heart failure, it will gradually result in dilatation of the ventricular chambers, because more preload means the ventricles has to adapt to this preload, to this extra preload, and it can adapt to the extra preload by becoming more dilated to accommodate more blood. And so for that reason, a buildup of pressure here and in the left ventricle, in the left atrium, it will be more gradual compared to acute heart failure, because the size of the left atrium, when you compare a heart of a patient with chronic heart failure with the heart of the patient of acute heart failure, the size of the left atrial chamber, it will be larger than the size of the left atrial chamber in acute heart failure. So the left atrium will become more dilated, and so it can accommodate more blood. And so pressure here will be increased, but it will be to lesser extent compared to acute heart failure, because the size of the chamber will accommodate more blood, and so it will accommodate more pressure. And so for that reason, there is less transmission of pressure and less buildup of pressure in the pulmonary veins. And so there is less pressure in the pulmonary capillaries. And so there is less leakage of plasma fluids into the interstitium. And because a condition is slowly developing and the pressures are gradually increasing and the edema is slowly developing, in patients with chronic heart failure, the lymphatic system will do a good work in removing and draining the edema fluid. So this edema which is produced will be drained effectively by the lymphatic system. And so the patient will end up with no edema or with minimal edema in patients with chronic heart failure. On top of that, another important compensatory mechanism that develop with patients with left heart failure, whenever there is increase in the pressure here in the pulmonary venous side, in the pulmonary veins, this will trigger arterioconstriction in the pulmonary arterial system. Here, this is the venous system, and this is the arterial system. The pulmonary arterioles here will become constricted in response to high pressure in the pulmonary veins and in the pulmonary capillaries. And this pulmonary arterioconstriction basically means there is pulmonary hypertension. When there's arterioconstriction here, that means the pressure within the pulmonary arterial circulation is high. So there is pulmonary hypertension. This pulmonary hypertension is initially, it's protective to patients with left heart failure because it will protect these patients from edema. Because when there is arterioconstriction here, that means a flow of blood from the right side of the heart into the pulmonary arteries, into the arterioles. This will result in less flow of blood from the arterioles to the capillaries. فما يكون في less blood flowing into the capillaries here, that means less blood flowing into the veins. This will lead to less congestion in the pulmonary veins, وبالتالي less pulmonary capillary pressure. When there is reduced blood flow to the capillaries, that means there is less pulmonary capillary pressure. And when there is less pulmonary capillary pressure, there is less risk of edema formation. So as you can see, a pulmonary arterioconstriction that develops here in association with left heart failure will protect the lungs from pulmonary edema. And this is only seen in chronic heart failure. And if the left heart failure is developing gradually over years, not suddenly. And seen with chronic, not with acute. And so for that reason, a patient with chronic heart failure, they tend to have no edema or minimal edema. And their main symptoms are coming from a congestion of blood. While an acute heart failure, there is no time for the compensatory changes to develop. And so the size of the chambers are normal and non-compliant. And so the pressure will rise rapidly. And it will result in frank pulmonary edema eventually. So this is the concept of left heart failure. The same concept is also applied to the right heart failure. Right heart failure can, again, when there is right heart failure, there is a reduction in the right ventricular output as well. The right ventricle normally should open the blood into the pulmonary circulation. When there is a reduction in the right ventricular output, the pressure in the right ventricle will increase. And again, the pressure in the right atrium will increase. And when the pressure in the right atrium is increased, that means a caval system will not drain the blood completely into the right atrium. And so the pressure in the caval system and in the systemic veins will go up. And so the tissues which are drained by the systemic circulation will become congested. For example, the liver will become congested and the patient will develop tender hepatomegaly. The jugular veins will become congested and the patient will have raised jugular venous pressure. The peripheral veins also will become congested and the patient will develop peripheral edema, which could be in form of lower limbs edema, or it could be sacral edema, for example. And the splanchnic circulation also, which eventually drain into the systemic circulation, will become more congested, and this will result in ascites eventually. And so these are all features related to right side or right heart failure. So in left heart failure, there is pulmonary venous congestion, while in right heart failure, there is systemic venous congestion. Then we have biventricular failure, which basically means both left and right ventricles are failing. There are two scenarios in which biventricular failure can develop. It could be either due to a disease process affecting both sides of the heart simultaneously. The classical example is dilated cardiomyopathy, which tends to affect both sides of the heart. It leads to dilatation of all four chambers of the heart. And so it results in biventricular failure. Also, sometimes ischemic heart disease can affect both sides of the heart, and so it can lead to biventricular failure. The other scenario in which biventricular failure can develop, as we know, is with long-standing left heart failure. Because long-standing left heart failure, chronic left heart failure, will trigger, as I said, pulmonary arterioconstriction. And this pulmonary arterioconstriction basically means there is pulmonary hypertension. When there is pulmonary hypertension, this is equivalent to systemic hypertension. مع systemic hypertension بيكون في زياده في التوتال peripheral resistance, and that means انه الافتر لود on the left side of the heart is high. With pulmonary hypertension there is pulmonary resistance, there's pulmonary arterial resistance, which will increase the afterload on the right side of the heart. And when there is too much afterload on the right side of the heart, eventually, with time, this can precipitate right heart failure, because when there is too much afterload, the right side of the heart will eventually not be able to produce adequate cardiac output. And this can precipitate right heart failure. So long-standing left heart failure can be followed by right side heart failure secondary to pulmonary hypertension. So it goes like that. It starts as left heart failure, which will result in pulmonary hypertension, and then pulmonary hypertension will precipitate eventually right heart failure, and this will result eventually in biventricular. We'll give a picture of right biventricular failure. So let's try to talk about the possible mechanisms by which the different etiologies of heart failure can develop. As we know, heart failure has a lot of possible causes. We would like to know the concept by which these underlying conditions can result in heart failure. We will use some important physiological concepts. As we know, blood pressure equals cardiac output divided by total peripheral resistance. So that means blood pressure is directly proportional to the cardiac output and directly proportional also to the total peripheral resistance. Then we know that the cardiac output equals the stroke volume by the heart rate. So increasing the heart rate as well as increasing the stroke volume will result in increasing the cardiac output. And the stroke volume itself, the stroke volume is the volume and the amount of blood ejected per each contraction, is dependent on three factors. It depends on the preload, it depends on the myocardial contractility, and it depends on the afterload. The relationship between the stroke volume and these three factors is different. A stroke volume is directly proportional to the preload. الزيادة في البريلود it's supposed to increase the stroke volume, while a decrease in the preload will result in decrease in the stroke volume. علاقة طردية. The same thing also applies with myocardial contractility. It's directly proportional to the myocardial contractility. When you increase the contractility, logically this will increase the stroke volume. And when you reduce the contractility, this will reduce the stroke volume. While the relationship with the afterload is reversed. It's inversely proportional to the afterload. علاقة عكسية. كل ما زاد الافترلود كل ما الستروك فوليوم هينقص، فبالتالي الكاردياك اوتبوت هينقص. And the opposite is true. كل ما نقص الافترلود كل ما الستروك فوليوم will increase. And that's why pulmonary hypertension here, a long-standing pulmonary hypertension eventually can lead to right heart failure, because pulmonary hypertension, it means the afterload on the right side of the heart is high. And the afterload is indirectly or inversely proportional to the stroke volume. So when there is high afterload, that means the stroke volume generated by the right ventricle will be low. And when the stroke volume is low, the cardiac output is low. And so this means there is heart failure. So that means in order to have heart failure basically means there is inadequate cardiac output, simply. So inadequate cardiac output can either be due to problem with the heart rate, or it can be due to problem with the stroke volume. Problems related to the heart rate, disorders of rate and rhythm, are called arrhythmias. And arrhythmias, whether it's tachyarrhythmia or bradyarrhythmia, are well-known causes of heart failure. But we will not talk about arrhythmias here. Arrhythmias in general, they tend to present with acute heart failure. We will focus here on the stroke volume. So our causes, the conditions which leads to heart failure, it can either affect the heart rate or it can affect the stroke volume. The conditions which affect the stroke volume, it will affect one of the three factors that are controlling the stroke volume. And it's either affecting the preload or the myocardial contractility or the afterload. Or sometimes you can have combination of two or more factors at the same time. So let's talk first of all about conditions that affect the myocardial contractility, because these are the major and the most important causes of heart failure. And most important causes of heart failure are here, affecting the myocardial contractility and so affecting the stroke volume. Here, immediately, we can put myocardial infarction and ischemic heart disease in general. And ischemic heart disease and myocardial infarction tend to precipitate and tend to cause heart failure by impairing myocardial contractility. And since a myocardial contractility is directly proportional to the stroke volume, so that means impaired myocardial contractility will result in drop in stroke volume. And since the cardiac output is directly proportional to stroke volume, that means in reduction in the stroke volume will mean reduction in the cardiac output. So this is how myocardial infarction or ischemic heart disease results in heart failure. Then also in this category, we can think of dilated cardiomyopathy and myocarditis. With dilated cardiomyopathy and myocarditis, there is pathological dilatation of the ventricular chambers. And as I said previously, whenever there is dilatation of the ventricular chambers, this will impair contractility. Dilated myocardium means hypocontractile myocardium. And in dilated cardiomyopathy and in myocarditis, the whole ventricular myocardium is affected. And so the whole ventricular myocardium is less contracting. And this is called global hypokinesia. And it can be evaluated on echocardiography. On echocardiography in patients with dilated cardiomyopathy, you will detect that the whole myocardium is contracting poorly. And this is called global hypokinesia. So it's a contractility problem. In myocardial infarction, because the problem is focal, there is a focal area of infarction, could be in the anterior wall, on the lateral wall, on the septal wall, whatever. This focal area will contract poorly, while the rest of the myocardium might contract well. So you will have segmental hypokinesia. Yani there is a specific segment which is hypokinetic, yani less contracting. Unlike dilated cardiomyopathy, in which the whole myocardium is contracting less. So in myocardial infarction, you have segmental hypokinesia, while in dilated cardiomyopathy, you have global hypokinesia. And together, these are conditions that result in heart failure by specifically affecting this component, which is myocardial contractility. Yani there is impaired myocardial contractility, which will result eventually in reduction in the cardiac output. Then let's talk about this component, which is the preload. And here, actually, there are a lot of talk here in this section, preload. As we know, as we said, stroke volume is directly proportional to the preload. Yani, logically, when there is increase in preload, the stroke volume should increase. And this is according to Frank-Starling law. When there is more preload, the myocardial cells will become more stretched, and so it will contract more. And when it contracts more, it will produce more stroke volume and more cardiac output. So logically, it means that drop in the stroke volume will develop when there is reduction in the preload. يعني when يكون في reduction in the preload, this will result in drop in the stroke volume. And this is true. And there are a group of conditions associated with heart failure in which there is reduced preload. And main problem is reduced preload. The problem is not in contractility, the problem is in the preload, which is reduced. And these disorders that affect the preload and result in reduced preload, these are the causes of heart failure with preserved ejection fraction. When you hear heart failure with preserved ejection fraction, here immediately you should think of reduced preload. This is the primary problem in these patients. Because in heart failure with preserved ejection fraction, this term previously was called diastolic heart failure. And with diastolic heart failure, the contractility function of the heart, the systolic function of the heart is normal. And it's unlike myocardial infarction. Myocardial infarction of dilated cardiomyopathy, the problem is systolic. And so a myocardial infarction of dilated cardiomyopathy will cause systolic heart failure, or heart failure with reduced ejection fraction. But in heart failure with preserved ejection fraction, or with previously called diastolic heart failure, the contractility is intact. The systolic function of the heart is normal. The problem is in the diastolic function of the heart. The diastolic function of the heart is the relaxation of the ventricular chambers during the diastolic phase in order to accommodate the blood. In patients who are having diastolic heart failure or diastolic dysfunction or heart failure with preserved ejection fraction, these patients, they have restricted or reduced relaxation of the ventricular chambers during the diastolic phase. The ventricles will not relax completely during the diastolic phase. And this could be either due to disease affecting the myocardium or due to disease outside the myocardium. Example for diseases affecting the myocardium and leading to diastolic dysfunction when there is pathological hypertrophy of the myocardium. Pathological hypertrophy in the myocardium basically means the myocytes will become thicker. The myocardium will become thicker. An increase in the thickness of the myocardium, it happens when the heart is exposed to high afterload. When يكون في high afterload, the response of the ventricular myocardium is by undergoing hypertrophy. A classical example is with systemic hypertension. We have a patient with long-standing systemic hypertension, which is not treated well. This systemic hypertension basically means the heart has to generate high pressure to overcome the total peripheral resistance, because systemic hypertension means there is increased total peripheral resistance. A resistance is coming especially from the arterioles. So the heart has to generate higher pressure in order to overcome the resistance, in the peripheral resistance. And without generating this high pressure, it will not be able to open the aortic valve from the start. Yani it has to generate pressure higher than the pressure in the total, in the peripheral circulation, in order to open the aortic valve, in order to allow the forward passage of blood from the left ventricle into the systemic circulation. So this high pressure, which is generated by the heart during the systolic phase in patients with hypertension, it means there is high afterload. Because afterload, as I said, is the pressure. It's not a volume like preload. Afterload is the pressure in the ventricular chamber during the systolic phase. فكل ما كان في increased total peripheral resistance، كل ما هيكون في more pressure generated during systolic phase، فبالتالي more afterload. And in order for the heart to be able to overcome this high afterload, it will undergo some changes. And these changes are in form of hypertrophy. The muscle will become more hypertrophy, it will become thicker. And when it becomes thicker, it will be able to contract more forcefully. And so it will be able to generate more pressure to overcome the total peripheral resistance. So as part of compensatory changes that happen with long-standing hypertension, which is not treated properly, is the development of left ventricular hypertrophy. And this is some sort of compensatory mechanism. This left ventricular hypertrophy will help the ventricle to generate more powerful and higher pressure to overcome the total peripheral resistance. But the problem is, yes, here the hypertrophied myocardium is having more contractile force, it's having more systolic function, but the problem is this is at the expense of the diastolic function, because when the muscle is hypertrophied, it will contract more forcefully, but it will relax less efficiently, because the muscle now is stiff. And when it becomes stiff, it will become less compliant. Think of this like a bodybuilder. And bodybuilders, because they are lifting heavy objects over and over again, their muscles will become thicker. They will gain more muscle mass. And the same thing also applied to the heart. When the heart is facing high total peripheral resistance, it has to generate more muscle mass, and so it will become hypertrophied. But this hypertrophy will restrict the flexibility of the ventricles, and so it will become a relaxation phase. It will become less efficient. It will not relax properly, and it will not relax efficiently during the diastolic phase. So these patients are not having problem with the systolic function of the heart, and actually the systolic function initially are well preserved and even stronger than the normal individual. But the problem is in the diastolic function of the heart, in the relaxation mechanics of the heart. The ventricle will not relax completely. And when it's not relaxed completely, it will not be filled with blood completely. And so that means the preload will be low, because the preload basically means the amount of blood at the end of the diastolic phase. If it's not relaxing completely, that means it will receive less blood during the diastolic phase. And so when you evaluate the blood at the end of the diastolic phase, it will be low. And so the preload is low. So conditions associated with diastolic heart failure or heart failure with preserved ejection fraction, they have a problem here in the preload. They have reduced preload. Pathological myocardial hypertrophy is an example. For example, due to systemic hypertension, also associated with aortic stenosis, can give similar problem. The same thing can be applied to the right side of the heart. The right side of the heart, instead of systemic hypertension, we have pulmonary hypertension. Instead of aortic stenosis, we have pulmonary stenosis. Then we have other possible causes that reduce the preload and result in diastolic dysfunction other than hypertrophy. it could be due to restrictive cardiomyopathy. It's a type of cardiomyopathy in which usually there is some infiltrating or infiltrative disease. For example, like hemochromatosis, where there is infiltration of the myocardium with iron. Also in sarcoidosis, where there is infiltration of the myocardium with granulomas. Amyloidosis, this is a very important cause of restrictive cardiomyopathy in UK. In amyloidosis, there is infiltration of the myocardium with abnormal light chains, abnormal proteins. And also with malignancy, if there is metastasis, carcinomatosis of the myocardium, there might be infiltration of the myocardium with malignant cells. Or there might be fibrosis of the myocardium with systemic sclerosis, scleroderma. Sometimes systemic sclerosis can affect the myocardium and it can lead to fibrosis within the myocardium. So all these conditions will eventually result in restrictive cardiomyopathy. And restrictive cardiomyopathy, from the name, you can understand that the problem here is cardiomyopathy means disease of the heart muscle. Restrictive, it means the disease here is restricting the expansion and the relaxation of the myocardium with the ventricular chambers. So here, because the myocardium is heavily infiltrated by disease or it's fibrotic, it will not relax during the diastolic phase completely. It might have preserved contractile function, although حتى contractile function becomes impaired in these patients. Like the main problem is in the diastolic function. The ventricular chamber will not relax properly during the diastolic phase, and so also the preload will be low in these patients. And this will be considered as heart failure with preserved ejection fraction. Then, as I said, sometimes a diastolic heart failure or heart failure with preserved ejection fraction, it could be due to problem outside the myocardium. And myocardium itself is healthy. Outside the myocardium means there is a problem in the pericardium, in the pericardial sac covering the heart. And this could be either constrictive pericarditis, which usually seen in the setting of tuberculosis, for example. With constrictive pericarditis, what happens is the heart is enclosed in calcified pericardium. The pericardium will become calcified and fibrotic. And so it will restrict the mobility of the heart. It will restrict the relaxation of the heart. Again, similar to restrictive cardiomyopathy. But here the restriction to the relaxation is not coming from the myocardium. It's coming from the pericardial sac. Because the pericardium is calcified, it's becoming stiff, and so it will restrict the relaxation of the ventricular chambers. And so this can also result in reduction in the preload, and this will result in reduction in the stroke volume and heart failure. Other than constrictive pericarditis, also patients who are having pericardial effusion, when there is also buildup of fluids within the pericardial sac, eventually this also will restrict the relaxation of the ventricular chambers, and it will precipitate also reduction in the preload, and this will result in heart failure. So all the causes of heart failure with preserved ejection fraction, which is also called diastolic heart failure, they will cause heart failure by the mechanism of reduced preload. And the reduction in the preload is related to impaired diastolic function of the heart, not the systolic function. Then also, there is an important point also related to the preload here. Low preload can cause heart failure, as I said, to reduce the stroke volume. And high preload, it will increase the stroke volume and it will increase the cardiac output. But as I said previously, if the preload was excessive and beyond the physiological limits of the heart, at that point, an increase in the preload will become pathological. And when it becomes pathological, it will exert paradoxical effect. And instead of increasing the stroke volume, it will actually reduce the stroke volume. So that means a reduction in the stroke volume, it could be either due to low preload or it could be due to excessive increase in the preload. So what are the conditions that results in excessive increase in the preload? An excessive increase in the preload, also it's called chronic volume overload. لما نقول excessive preload, it means there is volume overload. There are a group of conditions that leads to chronic volume overload. A classical example in which, as we know, طبعا heart failure itself, as part of the pathophysiology, heart failure eventually will result in excessive preload. الهارت فيلير itself is associated with excessive preload. والاكسسيve preload اللي بيحصل مع الهارت فيلير هو contributing in the deterioration and worsening of heart failure. But I would like to know what are the conditions which primarily from the beginning and from the start result in heart failure due to excessive preload. يعني the initial problem is excessive preload. Excessive preload here is not compensatory. It's not due to activation of the neurohumoral mechanisms. The excessive preload is directly related to the underlying cause. The classical example of conditions associated with volume overload or excessive preload are regurgitating valvular diseases like mitral regurgitation and aortic regurgitation when you talk about the left side of the heart. Equivalent on the right side of the heart, we have tricuspid regurgitation and we have aortic pulmonary regurgitation. And also we have other conditions like intracardiac blood shunt, and this is classically seen with congenital heart diseases like ventricular septal defect and atrial septal defect. These are examples of the disorders that eventually result in heart failure by placing the heart under volume overload. يعني by excessively increasing the preload. في aortic regurgitation, for example, as we know إنه البروبلم is إنه aortic valve is incompetent. during a diastolic phase, normally an aortic valve is supposed to be closed. This is the normal mechanics of the aortic valve. It should be closed during the diastolic phase. During the diastolic phase, you only want a mitral valve on the left side of the heart to be open, while the aortic valve should be closed. But because there is aortic regurgitation, the aortic valve is incompetent, and so during the diastolic phase, the blood will start to regurgitate from the aorta into the left ventricle through the aortic valve, because the aortic valve is incompetent. So that means during the diastolic phase, in patients with aortic regurgitation, the left ventricular chamber will receive blood coming from two directions. There is blood which is coming from the normal direction through the mitral valve, which is open normally, and there is blood which is regurgitating back from the aorta through the aortic valve. So you can imagine if the blood is coming from two directions to the left ventricle, you can imagine that in the left ventricle at that point will be exposed to very high preload. Yani the volume of blood which will be present at the end of the diastolic phase, it will be very high. And so that means aortic regurgitation will result in volume overload state. It will increase the preload significantly. And so this is a primary problem which will result in heart failure. يعني هنا البريلود زيادة في البريلود not coming as a compensatory mechanism with heart failure. Here, the increase in the preload is the primary problem that has led to heart failure. I hope this point is clear. The same thing is also applied with mitral regurgitation. In mitral regurgitation, the mitral valve is incompetent. When it's supposed to be closed, it will be leaky. And normally, a mitral valve is supposed to be closed during the systolic phase. في السيستوليك phase المفروض mitral valve to be closed والaortic valve هو اللي يفتح in order for blood to be pushed and to move forward into systemic circulation. But with mitral regurgitation, during the systolic phase, when the left ventricle starts ejecting the blood will move into two directions. Part of the blood will go forward normally through the aortic valve, which is normally opening into systemic circulation, but there is some regurgitating jet of blood. Yani there is some blood which will move backward instead of moving forward. Some of the blood will be regurgitating backward through the mitral valve into the left atrium. And so that means on the next cardiac cycle, during the diastolic phase, on the next cardiac cycle, there will be more load of blood coming to the left ventricle because يعني a venous return will arrive, and along with the venous return, the blood which was regurgitated into the left atrium from the previous cycle will be added to the venous return, and so all this extra load of blood will go to the left ventricle during the diastolic phase, and so again the left ventricle will be under volume overload. And remember, يعني forward blood that is moving forward is less than normal, and so the cardiac output is low because blood part of the blood is going backwards, not moving forward, and so the cardiac output will drop. And this drop in the cardiac output will activate the neurohumoral factors as we discussed, and among these neurohumoral factors, aldosterone and ADH will result in water retention. which will increase the blood volume. So a venous return will be increased. It will not be normal. So the heart is receiving more and more blood with each cycle due to retention of water by the action of aldosterone and ADH. And eventually the heart will be under volume overload. So mitral regurgitation and aortic regurgitation, they result in volume overload. Ventricular septal defect and atrial septal defect, they also result in volume overload state because they lead to intracardiac shunting of blood. We're not going to go into details now. Also, conditions associated with hyperdynamic circulation, like anemia, like pregnancy, and like thyrotoxicosis. These three conditions are associated with hyperdynamic circulation. In these conditions also, there is increased preload with the hyperdynamic circulation. And these conditions are associated with high output heart failure. The term high output heart failure usually applied to these three conditions. These are the commonest causes of high output heart failure. Anemia, severe anemia, pregnancy, and thyrotoxicosis. Also, there are less common causes like beriberi, thiamine deficiency, for example, or patients who are having AV fistula for dialysis, for example. Paget's disease of the bone is another example, but these are less common conditions. When you think about high output heart failure, remember three important causes: pregnancy, severe anemia, and thyrotoxicosis. In all these conditions, there is a hyperdynamic circulation, and hyperdynamic circulation basically means there is excessive preload in the heart. And so this also can be a cause of heart failure, like this will be considered as high output heart failure. The heart is structurally normal, but the demands of the peripheral tissues is increased, exaggerated. So cardiac output, which is adequate for normal individuals, it will not be adequate for those individuals who are having thyrotoxicosis and pregnancy and thiamine deficiency. They will require an extra cardiac output. And this is called high output heart failure. So these are examples of conditions that result in heart failure by increasing the preload, by causing volume overload. Then let's go finally to the third category, here conditions that result in heart failure by affecting the afterload. And afterload, as I said, is inversely proportional to the stroke volume, يعني عكسيا, علاقة عكسية. So increasing the afterload will result in reduction in the stroke volume. So you can think that in any condition that increases the afterload significantly will reduce the stroke volume. And again, heart failure itself, due to the compensatory mechanisms, eventually there is increased afterload. And so increased afterload eventually will worsen the cardiac output. Although initially an increased afterload is beneficial by increasing the blood pressure, like eventually on the long term, it has a negative impact on the heart and will directly reduce the cardiac output due to a relationship between stroke volume and afterload. So what are the conditions that increase the afterload? Increasing the afterload means the pressure generated by the ventricles during the systolic phase is high. طيب when the ventricles has to generate very high pressure during the systolic phase. This happens when there is resistance to the flow of blood from the left ventricle to the systemic circulation. This resistance to the flow of blood from the left ventricle to systemic circulation, it could be at the level of the arterioles. In patients with systemic hypertension, there is increased total peripheral resistance. Or this resistance could be inside the heart, at the level of the aortic valve, with the aortic stenosis. ما هو afterload هو pressure generated by the ventricle to open the aortic valve during systolic phase. إذا كان في aortic stenosis معناتها هنا ventricle has to generate much higher pressure than normal to open the aortic valve, because the aortic valve now is stenotic and calcified. So aortic stenosis is associated with very high afterload. Equivalent to aortic stenosis on the right side of the heart, we have pulmonary stenosis. Equivalent to systemic hypertension on the right side of the heart, we have pulmonary hypertension as a cause of right heart failure. Also, we have a condition called hypertrophic obstructive cardiomyopathy. This is a type of cardiomyopathy in which there is pathological hypertrophy of the myocardium and there is asymmetrical hypertrophy of the myocardium in which a septum, especially an interventricular septum, is hypertrophied. And this pathological hypertrophy of the interventricular septum will protrude into the left ventricular lumen cavity, and it will obstruct the flow of blood from the left ventricle into the aorta. And so here the obstruction is considered subvalvular obstruction, يعني below the aortic valve. This is called hypertrophic obstructive cardiomyopathy. Also here, the patient will have very high afterload. In order for the left ventricle to overcome this obstruction, it has to generate higher pressure, very high pressure. And so HOOCAM, or hypertrophic obstructive cardiomyopathy, is an important cause of heart failure by affecting the afterload, by increasing the afterload. Also, increasing the afterload could be supravalvular, يعني not subvalvular, يعني something above the aortic valve, after the aortic valve. Classical example is coarctation of the aorta, which is a congenital heart defect in which there is congenital narrowing of the descending aorta, usually distal to the origin of the left subclavian artery. And after the origin of the left subclavian artery, the descending aorta will become narrowed. And this is called coarctation of the aorta. It's a congenital condition. When there is narrowing in the aorta, that means there is resistance to the flow of blood from the left ventricle into systemic circulation. And so that means the left ventricle has to generate higher pressure, higher afterload to overcome this resistance. And so the afterload again here will be elevated. So بمعنى آخر an increase in afterload, it means there is left ventricular outflow obstruction. So any condition associated with left ventricular outflow obstruction will result in heart failure, like aortic stenosis, like hypertension, like coarctation of the aorta, and like HOOCAM. Well, ventricular outflow obstruction will increase afterload. Basically, it means the ventricle is under pressure overload. لما يكون في زياده في البريلود بنقول الفنتريكل is under volume overload. لكن لما يكون في زياده في الافترلود بنقول الفنتريكل is under pressure overload. So there are conditions of heart failure in which the heart is under volume overload, and there are situations in which the heart is under pressure overload. And this is a very important concept because there are specific changes associated with volume overload on the myocardium, and there are specific myocardial changes that develop with pressure overload. لما يكون في pressure overload, لما يكون الميوكارديوم is under pressure overload, like in hypertension, as I said previously, the myocardium will undergo hypertrophy initially. And this hypertrophy is essential for the myocardium to generate more pressure to overcome the resistance, as I said. And this is called concentric hypertrophy. The term concentric hypertrophy, it means there is pathological hypertrophy of the myocardium in response to pressure overload. There is another form of hypertrophy seen with volume overload, not with pressure overload. With volume overload, like in mitral regurgitation or aortic regurgitation, the myocardium will undergo eccentric hypertrophy. An eccentric hypertrophy, it means the hypertrophy is accompanied by dilatation. And this makes sense because when you have a problem pressure overload, we need to generate high pressure. And so we need more muscle, more contraction. And so that's why there is only hypertrophy without dilatation. This is called concentric hypertrophy. But in volume overload, we need to generate more pressure, but also we need to make more space for the extra load of blood, for the extra preload. And so for that reason, the hypertrophy should be accompanied by dilatation, because dilatation of the myocardium, it will increase the radius and the diameter of the ventricular chamber, of the ventricular cavity. And when the radius or the diameter is increased, it will accommodate more blood. And this is required if the patient is facing volume overload. And that's why in heart failure, eventually, there is dilatation. Because in heart failure, eventually, there is volume overload. In heart failure, as we said, بيحصل excessive preload eventually. But the kind of problem with excessive preload from the beginning, this will trigger eccentric hypertrophy, in which there is hypertrophy with dilatation simultaneously from the start. And that's why when you assist patient with aortic regurgitation or patient with mitral regurgitation, on examination, always الapex بيكون displaced. On chest X-ray, always you will detect cardiomegaly. But when you assist patient with aortic stenosis or hypertension, systemic hypertension associated with heart failure, when you assist the apex, it will not be displaced usually, especially in the early years. And when you do X-ray, you will not detect cardiomegaly, because in these patients there is only hypertrophy, but there is no dilatation. Cardiomegaly or displacement of the apex beat is coming from the dilatation of the heart. But again, even pressure overload, yes, initially pressure overload بيعمل hypertrophy without dilatation, لكن eventually مع البريشر اوفرلود بيكون في هارت فيلير as we said، فبالتالي بيحصل reduction in the cardiac output، وبيحصل كل الكلام ده اللي هو activation of the neurohumoral mechanisms، Eventually, with activation of neurohumoral mechanisms over years, there is more sodium and water retention, and there is increase in intravascular volume. So over the years, the preload also will increase. يعني initial problem is increase after load. لكن eventually, due to failing heart, the preload will start to increase. But increasing the preload here is a consequence of heart failure. It's not the primary problem. So those patients who are having concentric hypertrophy, and hypertrophy due to pressure overload, initially, yes, they have only hypertrophy without dilatation. But after several years, the heart will start to become dilated, and at that point, hypertrophy will be accompanied by dilatation. Hope this point is very clear. Remember, pressure overload conditions will result in concentric hypertrophy, in which there is hypertrophy initially without dilatation. But over the time, after many years, dilatation will come after that. But eccentric hypertrophy is seen with volume overload states, in which hypertrophy is accompanied with dilatation from the start. So basically, it means, if you have a patient with aortic regurgitation, from the first year, you might detect cardiomegaly and displace apex beat. While a patient with aortic stenosis, you might detect cardiomegaly maybe after 5 or 7 or more years from the diagnosis, because initially there is only hypertrophy without dilatation. I hope this point is clear to differentiate between concentric and eccentric hypertrophy. في أي سؤال يا جماعة؟
والله لو قلت تاني يا بص يكون احسن.
اوكي.
بس الاسماء تكون واضحه. كونسنتريك
concentric و eccentric. concentric with the C, eccentric with the E. طيب البروبلمز are related to the preload or afterload. لما يكون في excessive preload it equal انه في volume overload. لما نقول excessive preload معناتها الهارت is under volume overload, like in aortic regurgitation or mitral regurgitation or VSD or ASD. لما نقول في excessive afterload, this is equivalent to pressure overload, like in aortic stenosis and like in systemic hypertension or hookah. طيب the response of the myocardium is different to volume overload and is different to pressure overload. With pressure overload, a myocardium will respond by concentric hypertrophy, meaning it will undergo hypertrophy alone without dilatation. Because مع pressure overload, we need more pressure to be generated. So we need more contraction. فبالتالي we need a myocardium to become hypertrophied, to become thicker, to generate more contraction. But with volume overload, the response of the myocardium is with eccentric hypertrophy, with E. An eccentric hypertrophy, it means hypertrophy is accompanied by dilatation from the start. Because in volume overload, here we do not need, here we need more, we don't just need to generate more contraction, but we also need to provide more space for the extra preload. And so for that reason, dilatation here is required from the start, لأنه في more preload. فالheart has to adapt to this extra preload by dilating the ventricular chambers. إذا ما حصل dilatation, الاكسترا load of blood هيمشي وين؟ هيمشي ورا، هيمشي للpulmonary veins to the systemic veins, and the patient will be symptomatic. And this happens in acute heart failure. For acute heart failure, there is no time for the chambers to adapt and to change its size. And so for that reason, the buildup في pressure become very fast. The patient will develop frank pulmonary edema. But chronic heart failure, because the condition is gradual, يعني for example عندك mitral regurgitation gradually يعني developing over years, it will take time. فبالتالي ventricle will adapt gradually by undergoing eccentric hypertrophy, يعني undergoing hypertrophy along with dilatation from the start. And this dilatation is very important to accommodate the extra load of blood. Well, hypertrophy is important to push an extra load of blood. فابقى again, pressure overload states associated with concentric hypertrophy, while volume overload states associated with eccentric hypertrophy. ممكن نتكلم على الكلام ده تاني زيادة لما نشتغل الفالفولار heart disease lecture. We'll talk about mitral regurg or aortic stenosis again. I hope كده everything is clear. في أي سؤال تاني؟
Yes, it's clear.
So let's have a 10 minutes break. So what are the main complications resulting from heart failure. Number one, we should talk about cardiac arrhythmias. This is a very important complication related to heart failure. And actually, approximately up to 50% of patients with chronic heart failure, the condition is associated with sudden death. Sudden death is seen in up to 50% of cases of chronic heart failure. And this is related to fatal ventricular arrhythmias. The mechanisms by which arrhythmias develop in patients with heart failure mainly related to the long-standing effect of the sympathetic nervous system. As we said previously, these neurohumoral mechanisms, they are beneficial for many reasons for many years, but eventually they exert negative effects and negative impact on the heart. So although they have a lot of advantages, but eventually they also have a lot of disadvantages. And some of these advantages are coming from the sympathetic nervous system stimulation on the heart. When there is chronic stimulation of the myocardium by sympathetic nervous system, this will increase the risk of cardiac arrhythmias because when there is stimulation of the myocardial cells by sympathetic nervous system, this will result in loading of the myocardial cells with calcium ions. By acting on the beta-1 receptors, the sympathetic nervous system will load the myocardial cells with more calcium ions to lead to more calcium influx into the myocardial cells. And calcium ions are positively charged ions, and so in excitable tissues like the myocardial cells, when it becomes loaded with calcium, with positively charged ion, this can shift the membrane potential from the resting membrane potential towards the threshold potential. And so this can result in spontaneous generation of an action potential in an excitable tissue. And when this happens in the heart, this can precipitate arrhythmias, can precipitate different types of arrhythmias. And so when there is chronic stimulation of the myocardium by the sympathetic nervous system, this will increase the risk of cardiac arrhythmias, and this is one of the major complications and one of the main cause of mortality in patients with heart failure. Then after that, another complication that we have is cardiac cachexia. Cardiac cachexia basically means weight loss and wasting associated with long-standing heart disease. And it tends to be multifactorial also in patients with heart failure. It's related to congestion of the gastrointestinal tract that is seen in patients with component of right heart failure. When there is right heart failure, as part of the systemic venous congestion, there is congestion of the gastrointestinal tract, and this will impair absorption of nutrients, and so this can result in weight loss. This is one of the contributing factors. Another contributing factor is related to the forward failure. As we know in heart failure, traditionally, we have features related to forward failure and features related to backward failure. And backward failure, these are the features of congestive manifestations like dyspnea, orthopnea, and like lower limbs edema and so on. But the forward failure is mainly related to reduced cardiac output. And this includes mainly fatigue, and also it can include muscle wasting. With forward failure, the patient also can have reduced perfusion of the skeletal muscles, and this eventually can result in muscle wasting, and this can contribute also in the development of cardiac cachexia in patients with heart failure. And development of cardiac cachexia is associated with adverse prognosis. Then also renal failure is an important association with heart failure, and it tends to be prerenal in origin. It's due to reduced renal perfusion. As we said, around 20 to 25% of the cardiac output is going to the kidneys. So when there is a drop in the cardiac output, this will impair the renal perfusion. And this can result in renal impairment and renal failure. Then also, renal failure, commonly in patients with heart failure, it can be iatrogenic. It can be induced by the treating doctors, and it's usually due to use of drugs like diuretics. Over-diuresis can result in volume depletion, and this can precipitate also prerenal azotemia. Also, other nephrotoxic drugs used in the management of heart failure, like, for example, ACE inhibitors. And ACE inhibitors can sometimes it can result in renal impairment, and especially if the patient is having some pre-existing bilateral renal artery stenosis. Then we have a lot of electrolyte disturbances that can be associated with heart failure. For example, hyponatremia is common with heart failure, and it's basically delusional hyponatremia. It's hypervolemic hyponatremia. It's mainly due to the effect of ADH, because ADH retains water, and so it will expand the blood volume, and it will dilute sodium in the blood, and so it can result in delusional hyponatremia. And along with that, hyponatremia also can be worsened by the effect of diuretics, like furosemide. It leads to urinary losses of sodium. And hyponatremia is one of the is one of the markers of bad prognosis in patients with heart failure. Along with hyponatremia, there are other electrolytes problems also that can be seen related to potassium, especially. Hypo and hyperkalemia both can be seen with heart failure. Hypokalemia can be found, and it could simply indicate secondary hyperaldosteronism, because with hyperaldosteronism, as part of the compensatory mechanisms in heart failure, it will result in sodium and water retention at the expense of potassium secretion. So it can lead to hypokalemia. But more importantly, hypokalemia should be considered as a side effect of diuretics, like loop diuretics, especially again, which are commonly used in heart failure patients. It can lead to hypokalemia. While hyperkalemia, it can be due to renal disease, renal impairment, or it can be also drug-related, seen especially with ACE inhibitors or angiotensin receptor blockers, or with aldosterone antagonists like spironolactone. And these are all used in the management of heart failure. So always with electrolyte disturbances, especially potassium, in patients with heart failure, you should always consider drugs as a possible cause. Then also patients can have impaired liver functions, and this is due to combination of hepatic congestion with right heart failure and also hepatic hypoperfusion. Although the liver receives dual blood supply from the hepatic artery and from the portal vein, but still with heart failure, hepatic congestion with reduced perfusion of the liver, when there is an element of right heart failure, eventually it can lead to impaired liver functions. And in long-standing cases, it can trigger liver cirrhosis, and this is called cardiac cirrhosis. This is classically seen with conditions like constrictive pericarditis, for example, because constrictive pericarditis, it mainly presents with features of right heart failure, although it can give you biventricular failure, like mainly and pronounced features become features of right heart failure, and it tends to be long-standing, and eventually it leads to cirrhosis of the liver. This is called cardiac cirrhosis. Then finally, thromboembolic complications are very important with heart failure. Thromboembolic complications, first of all, patients with heart failure, they have increased risk of venous thromboembolism, like DVT and like pulmonary embolism. And pulmonary embolism is one of the important cause of mortality in patients with heart failure. And this is according to Virchow triad, because as we know, predisposing factors for venous thromboembolism included in Virchow triad. It includes hypercoagulability, it includes blood stasis and endothelial injury. And heart failure, due to low cardiac output, it's associated with blood stasis. There is a stasis of the circulation when there is low cardiac output. So any low cardiac output state is a predisposing condition to venous thromboembolism. And to make things worse, also there is an element of immobility in patients with heart failure, because as we know, these patients, they can be very ill, and exertion, sometimes minimal exertion, can precipitate symptoms. And so for that reason, these patients tend to be more immobile. So there is an immobility, and which also increases the risk of venous thromboembolism. Then beside venous thromboembolism, also arterial thromboembolism is an important consideration in heart failure. And this is seen when there is an intracardiac thrombus. Because as we know, with heart failure, there is an abnormal hemodynamics inside the heart, especially if there was a structural problems, like valvular disease, mitral stenosis, for example. In these conditions, there is an increased risk of thrombus formation inside the heart due to stasis of blood within the ventricle, within the heart chambers. And this thrombus, which is formed inside the heart, can be a source of systemic embolism. It can result in systemic embolism. And so this systemic embolism can present, for example, with a stroke, or with the peripheral vascular occlusion, with gangrene, and so on. So Thromboembolic complications includes venous thromboembolism, and it includes also systemic embolism. So heart failure, for example, can be complicated with stroke. Next, let's talk about the diagnosis of heart failure. And here we will discuss the recommendations by NICE guidelines. According to NICE guidelines, all patients who are suspected to have heart failure should undergo a blood test called the N-terminal pro-BNP, N-terminal pro-beta, pro-B-type natriuretic peptide. As we know, BNP is one of the natriuretic peptides, along with the AMP, which are produced and released from the myocardium. And it's one of the neurohumoral mechanisms that are activated in heart failure, as we discussed previously. Whenever there is heart failure, the levels of BNP will become elevated in the blood. It will go up immediately whenever there is heart failure, because BNP is released from the ventricular myocardium in response to any sort of ventricular strain. And heart failure is the biggest strain to the myocardium. And so the levels of BNP will immediately go up. So the diagnosis of heart failure is very unlikely if the BNP level are within normal range, because this is does not explain heart failure, because with heart failure, the BNP levels should go up due to strain on the ventricular myocardium. And so, according to NICE recommendations, this is the initial blood test, pro-BNP. Although this test might not be available and it might be expensive in certain parts of the world, but still, this is the initial blood test that is recommended. So how can we do an interpretation of this test? First, you need to know that there are two separate tests. We have BNP level alone, and we have the N-terminal pro-BNP. What's the difference between these two markers? Initially, from the ventricular myocardium, brain natriuretic peptide, the initial form of BNP which is released is called pro-BNP. This is the initial form that is released from the ventricular myocardium. Pro-BNP is considered as pro-hormone or precursor. Pro-BNP, then after that, it will become cleaved and it will be converted into two proteins. It will become cleaved into BNP and NT-proBNP. BNP is the biological active form of the hormone. This is what will give the physiological effects of the hormone, which is natriuresis and vasodilatation. NT-proBNP is biologically inactive. It will be produced from pro-BNP, but this is not active form of the hormone. It will not produce the physiological effects. And for that reason, we depend and we prefer to test the NT-proBNP over BNP, because BNP, because it's biologically active, it's less stable and has shorter half-life. While NT-proBNP, because it's not biologically active, it has longer half-life. And so it's more reliable to be tested when you are evaluating heart failure. So the recommendation now is to test for the N-terminal pro-BNP, not BNP. This is a very important point. And then the results will guide us to the next step, because as we know, the most accurate diagnostic test of heart failure is echocardiography. BNP, it will not confirm the diagnosis of heart failure, because it will just give you a clue that there is some sort of strain to the ventricular myocardium. But this strain could be due to any cardiac problem without leading to heart failure. And so we will not depend on BNP alone to diagnose heart failure. BNP benefit is in when you have doubt, especially in acute heart failure, when you have a patient who's presenting with severe breathlessness, presenting with dyspnea, and on X-ray you found that the patient is having pulmonary edema, for example, and you want to know, is it cardiogenic pulmonary edema or is it non-cardiogenic pulmonary edema? One of the ways by which you can know is by checking the NT-proBNP or BNP level, because if it was negative, it was normal, this is against cardiogenic pulmonary edema. This will indicate that this is non-cardiogenic pulmonary edema. This is the most important benefit from this test. Then along with that also, according to the NICE guidelines, we use this test NT-proBNP to guide us about the urgency of specialist review and how fast do we need to do echocardiography, and how fast this patient needs to be checked by a specialist, and how fast this patient requires an echo to confirm the diagnosis. And this will be guided by the specific levels of the test. If the level was more than 2000, if NT-proBNP is more than 2000, this is equivalent to 400, more than 400 in BNP. This is considered as high level. And those patients with high levels, more than 2000, they should be referred and they require cardiology specialist assessment within 2 weeks with transthoracic echo. While those patients were having NT-proBNP level between 400 to 2000, in this level, it's called raised level. This is not high, this is called raised. Raised level require cardiologist assessment within 6 weeks, including echocardiography. Because this is how we apply readings and the levels of NT-proBNP test. If the levels was more than 2000, patient should be reviewed by cardiologist in 2 weeks, while if between 400 to 2000, it should be reviewed within 6 weeks. A normal level, less than 400, this is against the diagnosis of heart failure, and at that point here, you should start conducting workup and investigations for other differential diagnosis. Then along with this test, there are other investigations also, which are conducted in patients with suspected cases of heart failure. As we said, an echo is the gold standard test to diagnose heart failure. This is the most accurate test to diagnose heart failure. And NICE guidelines, they just recommend urgency of echo to be guided by the level of proBNP. They recommend to check the NT-proBNP before going for echo in patients with suspected heart failure. But echo still is the most accurate diagnostic test in patients with heart failure, because an echocardiography, it will give you an evaluation regarding the morphology and the functional status of the heart. It will evaluate the heart structurally and functionally. Structurally, it will identify if there are any valvular disease, which could be an underlying cause of heart failure, for example. It can assess also the thickness and the diameter of the ventricular chambers, if there is an element of hypertrophy and dilatation and so on as a consequence of heart failure. And functionally, because it can evaluate the ejection fraction. It can assess the fraction or the percentage of blood that is ejected out of the end-diastolic volume. The percentage of blood that is ejected with each beat is called the ejection fraction, and this can be evaluated by echocardiography. And according to the ejection fraction, as we discussed previously, we can categorize heart failure into either heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. So these are some of the benefits of echocardiography in the workup for heart failure. Then along with that also before echocardiography, the initial imaging or radiological tests that should be performed in any patient with suspected heart failure are chest X-ray and ECG. These should be performed in all cases, and even before doing echocardiography. A chest X-ray can show us a lot of clues related to heart failure. And these are especially seen in acute heart failure, because with acute heart failure, there is pulmonary edema, and so chest X-ray can be associated with a lot of findings. Like still, chronic heart failure also can give you a lot of radiological findings on chest X-ray. An ECG, in patients with heart failure with reduced ejection fraction specifically, it's almost impossible to have a patient with heart failure with reduced ejection fraction with normal ECG. Always there is some ECG abnormalities. And so ECG can give us a lot of clues about heart failure and about even the possible cause of heart failure. For example, if there is left ventricular hypertrophy, changes on ECG, this can indicate the cause might be pressure overload, like systemic hypertension, for example, or like aortic stenosis. Also, ECG can detect Q waves, pathological Q waves, which can indicate there is an old myocardial infarction, and this could be an underlying cause of heart failure. Also, ECG might show different types of arrhythmias. And arrhythmia itself can be a cause of heart failure, and at the same time, heart failure itself is complicated by arrhythmias. And a lot of different types of arrhythmias can be detected. One of the commonest types of arrhythmias, like atrial fibrillation, also ventricular ectopic beats tends to be common with heart failure, and they also reflect poor prognosis. And there are other also types of arrhythmias which can be detected on ECG as well. ECG also can detect some changes related to electrolyte disturbances like hypokalemia and hyperkalemia, which are commonly found also in patients with heart failure. Then after that, there are other blood tests that we can also request beside the NT-proBNP, CBC, and in CBC, anemia is a poor prognostic marker in heart failure as well, because anemia it can worsen the condition. Patients with heart failure, one of the important conditions that worsen, that's associated with worsening of heart failure, is anemia, and always should be corrected. Then also we can check renal function tests and electrolytes. And as I said, there are a lot of electrolyte disturbances that can develop with heart failure. Liver function tests also can be checked. And thyroid stimulating hormone, thyroid function test also is very important in the initial evaluation of heart failure, because thyrotoxicosis itself is a cause of heart failure, can lead to high output heart failure. Thyrotoxicosis can lead to arrhythmias like atrial fibrillation, which can lead to heart failure. And thyrotoxicosis, if it's not the underlying cause of heart failure, it could be a worsening factor. It could be a condition that worsens pre-existing heart failure. So it's very important to exclude possibility of thyrotoxicosis in the initial evaluation of heart failure. Then there are other investigations which can be added according to the clinical needs. For example, you can check the blood glucose. We can do urinalysis as well. So this is just X-ray showing some classical features in patients with heart failure. And radiological findings of heart failure on X-ray, on chest X-ray, can be remembered by the mnemonic A, B, C, D, E. A stands for alveolar edema. Alveolar edema is seen in the setting of acute heart failure. When there is frank pulmonary edema, the edema will not just be limited to the interstitium of the lung, but it will also start to fill the alveolar spaces. It is not seen here in this X-ray, but in alveolar edema, it will classically give a description which is called bat wings edema. It resembles the bat wings. And it appears as an area of a bilateral opacity, bilateral perihilar opacity radiating from the hilum of the lung, and resembling the bat wings. This is called alveolar edema. B stands for B lines or curly B lines. And curly B lines, these are one of the findings also associated with heart failure. It's seen here in this chest X-ray, but it might not be very clear here. It's usually seen here in the costophrenic angel. This appears like horizontal lines, and these horizontal lines are actually due to engorged lymphatic vessels. Because with heart failure, because there is pulmonary edema, the lymphatic vessels are draining the edema fluids, and so they will become engorged and congested, and they will give you curly B lines, which are found here in this area, appears as horizontal lines. And this reflects there is interstitial edema. Then C stands for cardiomegaly. And it's very obvious and clear here. As you can see, this heart is enlarged. You assess the cardiomegaly by assessing the cardiothoracic ratio. It's more than 50%. If it's more than 50%, then this is cardiomegaly, as you can see here. And cardiomegaly is seen with chronic heart failure. It's unlikely to be seen with acute heart failure unless there is pre-existing cardiac disease, but it's seen in chronic heart failure, especially in conditions associated with volume overload. And then after that, D stands for dilated upper lobe veins. As you can see here, if you focus here on the upper lung fields, in the upper lobes, you can clearly see the vascular markings in the upper lung zones. This is called dilatation of the upper lobe veins. Also, we call it diversion of the upper lobe veins, upper lobe diversion. Also, it's called cephalization of the upper lobe veins, because normally, in normal individuals without heart failure, vascular markings in the lungs are mainly seen in the lower zones of the lungs. The vascular markings are very clear in the lower zones of the lungs, but the upper zones of the lungs, due to the effect of the gravity, and because there is no element of venous congestion, The upper lobes of the lungs are showing more air and less vascular markings in normal X-ray. But in patients with heart failure, because there is pulmonary venous congestion, so the picture will change. The veins in the upper lobes will become congested, and it will be clearly seen. The vascular markings will be clearly seen on X-ray. So in patients with heart failure, vascular markings are not just seen in the lower zones as normal individuals, but also it will start to appear more prominently in the upper lung zones as well. This is called upper lobe diversion, or we can call it dilatation of the upper lobe veins. And this is an important sign of heart failure. Then finally, E stands for effusion. Pleural effusion can be seen also with heart failure. And pleural effusion usually seen in the setting of biventricular failure, because pleura drains, blood from the pleura is drained into the systemic circulation as well as the pulmonary circulation. And so for that reason, usually pleural effusion is seen when there is biventricular failure. And usually tends to be bilateral. But if it's unilateral, it usually tends to be on the right side, right-sided pleural effusion. In this patient, you can see there is cardiomegaly, and you can see there is upper lobe vein dilatation. These are the clear findings in this X-ray. So this is our diagnostic approach according to NICE guidelines. Patients with suspected chronic heart failure, after taking detailed history and perform clinical examination, you should request immediately NT-proBNP. And according to the level of NT-proBNP, you will decide how fast this patient requires cardiology assessment, within 2 weeks or within 6 weeks, or whether the diagnosis is unlikely if the BNP is less than 400. And simultaneously, with requesting the NT-proBNP, you should arrange other investigations, including ECG, chest X-ray, and blood tests. Then according to the BNP, as we said, if the NT-proBNP is more than 2,000, here refer urgently to be seen within 2 weeks by cardiologist and to do transthoracic echo. If the NT-proBNP level is between 400 to 2,000, here the patient needs to be referred within 6 weeks with transthoracic echo at that time. If the level is less than 400, here that means heart failure is not confirmed, and here you should consider other causes of the symptoms. So you should conduct other investigations. In those patients who will undergo cardiology assessment and echocardiography, after that, according to the transthoracic echo, either the heart failure will be confirmed by echo, and after it's being confirmed, we need to assess the severity after that, and then we need to establish the etiology. It's not just enough to diagnose heart failure. We have to establish the etiology of heart failure and to identify any correctable causes, because correctable causes basically means ممكن يكون في some factor that is worsening the condition. For example, like anemia, like thyrotoxicosis, like arrhythmia. These correctable conditions should be addressed in patients with heart failure. Or after echocardiography, the condition might not be confirmed, and then you have to consider alternative diagnosis. So this is our map and our diagnostic approach for heart failure.